So, key hormones with postpartum period. It starts right after that birth. And it's within the first 24 hours, you're going to see a drastic drop
Hey, Miss
immediately in
Nicole,
your estrogen. Yes.
can you pull up the PowerPoint and share your screen?
Okay. Give me 1 second. I am so
Sorry.
sorry.
It just
No,
makes it
it's
easier to
fine.
take notes without having to switch screens.
No, you're correct. I am sorry. Give me 1 second. Mm-mm-mm.
And like you can.
Okay. Can everybody see that?
No, ma'am.
Still no.
I can see it.
You can see it?
Yeah.
Yeah, there you go.
Okay.
There it is.
I'm sorry. Okay. Okay, so we are gonna go here. Sorry. Okay, so delivery to 6 weeks. It's the 4th trimester, and your immediate postpartum, first 24 hours. So right after delivery, within that first 24-hour period, you're gonna have an immediate drop in your estrogen and your progesterone levels. It's going to be mostly within that 90% drop within that first 24-hour period after the placenta is delivered. Okay. And then you're also going to have an increase in the prolactin and the oxytocin. So these are all hormones that our body naturally makes. And they increase in order to bring a more sustainable and suitable level to stimulate milk production and increase bonding with the baby. And that usually stabilizes within 3 to 6 months, and it can usually last up to a year in postpartum. So if you take that knowledge and you think about how people use breastfeeding for contraceptive methods, it makes a little bit more sense. So, having that in the postpartum period. So, early postpartum is considered to be day 2 to day 7. And that's usually leveling out the physiological changes and returning to normalcy. So that's more of like the hemodynamics. Our body tries to, stimulate more red blood cell production. Our hemoglobin and hematocrit try to keep up with the hemodynamic changes with the blood loss, whether it's a vaginal or a cesarean delivery. So your postpartum recovery care, your first 2 hours until stable. That's typical, whether it's protocol per facility or not. It is done by the labor and delivery nurse. Vaginal delivery, it's a labor and delivery nurse. And then I know some of my students that I've had in clinical have seen the labor and delivery nurse is trained to be the circulating nurse in cesarean sections. And I hope, the other campuses get to see these things as well, because it's wonderful to see. But, the labor and delivery nurse gets to have both of those roles. So they literally follow their patient through. They're doing vital signs, fundal checks, which again is the top of that uterus. So how it's coming back down and contracting back down. Our lochia, which is Q15 minutes, and we're going to go over that here in a few more minutes, every 1 to 2 hours. And that again can be institution protocol as well. We want to make sure that they have a clean gown, that we're keeping their pericare clean, and give them clean bedding, because deliveries can be quite messy. We try to keep everything contained, but it can get a little messy. Give them warm blankets, offer them oral fluids and some light solids, because during this process, they're usually not allowed to have anything solid to eat. In the chance that, something happens, things can go wrong. We keep them just on clear liquids. in case they need to have a stat cesarean section. Okay. So again, until the delivery. So we usually offer them something light because they've gone through all this trauma. There is a likelihood of them having some nausea and vomiting. And then ice pack to the perineum. Postpartum vital signs. So again, our standard vital signs, it might be slightly elevated in the first 24-hour periods, but then it will normalize to our standard vital signs. Your pulse will be 40 to 80 beats per minute. The puerperal bradycardia can occur. And it's just that normal fluctuation, and that decrease can occur. Respirations, it's what we normally have. If they have any increased respirations, or they're looking like they're having, trouble breathing or anything postpartum, use your assessment skills. Why are they having that? We all know if somebody's having difficulty breathing or something like that, why is it going on? And we also think in pregnancy, and we're going to go over this here in a few minutes too, postpartum, they're at risk for blood clotting, okay? So if they have hypercoagulability, did they have some type of blood clot happen? Is it in their lung? Okay, so taking it for what it is and putting it clinically, trust what you're seeing, trust your nursing judgment, okay? Your blood pressure within a usual range. Again, here, if they had, increased, high blood pressure before pregnancy, okay, what does that look like for them? What is their usual range prior to pregnancy? What did they look like when they came in? What on their admission? Okay, and is this something new? And then their pain, their goal, usually 0 to 2, but there again, pain based on cultural differences can be different, and we have to be, just taking for what they have to say for face value. Safety with ambulation. So, it's always helpful to have another nurse that you trust to kind of help you with some certain things, whether it be a backup cervical check or anything on the unit. Ambulation can be this thing too, because they're, they've had change in hemodynamic status. They've had all these narcotics. This is their first time getting up. They've had an epidural. They, had a spinal, whatever the case may be. This is their first time getting up. So we may need to have a little assistance here. We need to make sure we check their blood pressure first, make sure it's stable enough, see how they feel with change of position, okay, whether they're having some hypotensive issues on orthostatic changes. Elevating the head of bed for a few minutes, getting them acclimated to making those changes before ambulation. Having the patient sit on the side of the bed, getting used to it, and helping them stand and staying with them. Having them lock their knees and walk like a penguin can help. Gives them less likelihood for going down. So ambulating alongside the patient, providing support if needed. I usually, when I was in L&D, I used to keep an ammonia packet with me if it didn't explode prior to. But if I was walking my patient and I would take them to the toilet and we're doing the first void, I'd make sure I have it with me, because sometimes getting up, having those changes happen, they might pass out on you on the toilet. So if you pop the ammonia and go underneath their nose, it helps wake them up a little bit more. But again, letting somebody know that you're getting somebody up for the first time, getting on the toilet, and if you, hit the call button, there's a reason for that, okay? So again, frequently assess how they're feeling, if they're feeling lightheaded, dizzy, seeing spots, anything like that, and then staying close for assistance. Our physical assessment. So taking an assessment of mom is, in this type of period, is different than your med-surg patient. Okay, so we know we have a regular head-to-toe assessment that we take. Your postpartum assessment is going to be more of a focused assessment based on maternity. You want to make sure you're providing privacy. And this is throughout. And I know we've spoken on that, privacy, sensitivity in everything. Did somebody have a question?
I did.
No? What's up?
Oh, I'm sorry. I didn't realize it came off on mute. It does that. I swear I didn't touch it. I asked how long after an epidural can they get up to walk? And Miss Siska said usually 1 to 2 hours, depending on the block.
Okay. Yeah. That's usually about it. And everybody's different, depending on their bodies, how they handle anesthesia, things like that. It varies, but that's usually the standard time. So again, being sensitive to their issues, how they handle things, culturally sensitive, giving them privacy, keeping them covered, and make sure you're using the professional jargon. If they look confused, kind of break it down a little bit for them, okay? And helping them empty their bladder. Again, if they're unable to move their legs or unable to feel and we need to empty their bladder, we can do so with catheterization, whether it be straight cath or not. Position them in semi-Fowlers and then ask visitors to step out while we do this care, okay? And we're going to go into a little bit more of a focused review assessment and how we do that postpartum. So we use what's called bubble key, and we're going to start talking about that. So over here on the left-hand side is a picture of a pad and what we're looking for when we kind of break down the amount of lochia. Okay, lochia is the drainage that we have in the postpartum period. And it basically, in the next couple of pages, we're going to go over it, but this is what we're looking for. So the top is scant, the next is small, the third one is moderate, and then the last one is large. So if this ever if this ever appears for one of your patients and it's less than an hour, we want to be concerned and we want to notify the practitioner or the provider as soon as possible. If it's even within the immediate postpartum period, I mean, we need to be aware that this is happening. We need to know why. We need to do fundal checks and see where that bleeding's coming from. Is it coming from the uterus or is it coming from the vagina? Okay. In the middle here, this is called Rita. So as you can see, it takes a mnemonic and it breaks down the beginning of each word. And that's how we assess the perineum. Okay, so we know vaginal birth, a lot of trauma. Okay, so we're assessing redness, edema, ecchymosis, drainage or discharge, and approximation. A lot of people don't understand what approximation means. I always try to tell you approximation is how it approximates or how it meets. Okay, so how it adjoins. If they've had lacerations or they've had an episiotomy, the provider needs to suture it up. So we need to make sure that the bleeding is coming from uterine location, not perineal. Okay, so getting a good look at that and assuming where it's coming from is what we need to do. Okay, and this is how we evaluate that. Symptoms of a DVT. Remember, we're assessing pain, redness, swelling, and hot to touch, and this is unilateral. Okay, one-sided. So if they're having this, we need to let the provider know again, and they're usually going to order an ultrasound of that extremity to further evaluate that. Okay, so we can effectively treat them. And then on the bottom, it's showing some other things. This bottom right here is how to do a fundal assessment. So I was telling the group yesterday, we want to make sure we brace the pubic area, like the suprapubic area, and then we go from the top. And we're feeling for the top or the fundus of the uterus, and it needs to be firm, okay? And that's what it looks like. We're going to go into this a little bit more here. So again, we're starting with your vital signs. We're doing our pain assessment. If they have pain medicine on board, which they're going to, okay. And I will say here, and we have a very large epidemic of people who are with drug use, they may not have narcotics ordered because of drug use. So, take that for consideration and basically know your classes of meds. And this is where knowing your patient's history comes into play. So maybe NSAIDs are the only thing that they are able to have. Okay, so that's a good time to mention that. And then the time to assess emotional well-being, that starts at the door. Okay, you're visualizing how that patient is interacting with you and how they're interacting with their significant other or their child and their child. Okay, are they picking up their new role? Are they accepting of their baby? Are they struggling with that role? And we can kind of assess and intervene as necessary. So we start head, okay? We're assessing for cephalgia or a headache, okay? Also, are they having blurred vision or spots, lightheadedness, dizziness, flashes of lights, okay? These are all things that can signify postpartum preeclampsia, okay? These are like precursor or auras that can happen for preeclampsia. The headache can be worse when sitting up, but often improves when laying down. It does not improve. When laying down, it could indicate the spinal headache. I know we talked earlier with Miss Megan talking about the spinal headache too. I do know some things they try before they do a blood patch is introducing caffeine. Very, very rarely have I seen caffeine work for a spinal headache. They usually do end up having to go in for the blood patch. But, doing a really good assessment like this can figure out, what are we looking at? Is it actually just, I've pushed for so long, it's a headache? Is it related to an increase in blood pressure? Do we need to get lab work on this patient? Okay, there's going to be some lab work that might be thrown off with preeclampsia. Or what else are we looking at? So this is that bubble he that I was talking about. So if on the side it says if patient had a cesarean section, be sure to also assess your incision site. I try to talk about whenever somebody's complaining of pain in your postpartum period, assess all areas of pain. Yes, we know they're going to have abdominal pain when we're checking their fundus because we're going in there and we're pressing on their uterus and they just had a baby, right? So yes, their abdomen's going to be tender. Okay, their incision site is going to be tender, but checking the headache, checking for that leg tenderness. Okay, when we're checking those extremities, all very important. And also, I'm going to mention, and we're going to talk about this in the next couple lectures, epigastric tenderness is important too. Okay, and that's sometimes seen in later problems with preeclampsia, but is also needs to be mentioned. So when we go further down into this bubble he assessment, it's important. So here at the top, it talks about breasts. So we want to inspect, palpate the breasts. We ask our patients some open-ended questions. Are they intending to breastfeed? How do they feel about the breastfeeding? Are they strictly breast or are they also bottle? Are they soft? Are they filling? Are they firm? Are they also pumping? And then how can we help them? Are their nipples inverted? Are they, adequate for feeding? Do we need to get what's called a nipple shield? They do have those out on the units where it can be placed over the nipple to help the baby get a good latch. It's all patient by patient basis because everybody's different. Sometimes women need to hand express to get a little bit of what's called colostrum. Colostrum is that first good yellow gold, they say, for the baby, and that's got all those good vital nutrients. But those are all things we want to assess. If the woman says she does not want to breastfeed, there's some things we can teach them to prevent their milk from coming in. So you can have them use a firm fitting bra. When they go to shower, have them stand with their back towards the shower so that when the shower is running, the water does not directly hit their nipples, because when the nipples are stimulated, it can create the letdown reflex, which increases the prolactin to secrete breast milk. Okay, so again, if they don't intend on breastfeeding, we want to dry up that supply. That's something we want to encourage them to do. Also, I know cabbage leaves in their bra can help dry up the milk supply as well. Okay. Some other things with breast, even after they're discharged, you want to teach the moms, and this is all teaching related too for the mom. Okay, like, why are we giving this care? But it's very important that they understand why, because all of this is very new to them. Okay, when they go home and they're feeding and they get pain, why? Why is there pain? Is it one-sided? Okay, pay attention for them to if it's like very red, engorged, or enlarged. If it feels like an orange peel consistency, that can be consistent with what's called mastitis. And you might see that a little bit more later on in your readings. And that needs to be treated with antibiotic because that is a bacterial infection. But they do encourage mom to continue breastfeeding to help eliminate. And then clogged milk ducts can also occur. But just those are some starting things that you want to also educate mom on. When we move down here to the U, we have the uterus. So I know in a typical standard assessment, we always teach you to inspect the abdomen before we do anything. So inspect the abdomen. You're going to see the belly is still going to look semi-gravid, gravid being pregnant, right? But it's not going to be completely gravid because we've just had a baby. Okay, you're going to inspect, make sure there's no palpations of anything, because we have the intra-abdominal aorta. You might see that, you might not, but again, we're inspecting. And then you can take a listen to bowel sounds before we go ahead and palpate, and you're going to go ahead and you're going to palpate the uterus. So typically, after delivery, you're going to have the top of the uterus should be right near the top, or like at the umbilicus, or maybe one below, just depending on how many babies were in utero at that time, or what number of birth this is for the mom. It can vary. Okay. It needs to be firm. If it's not firm, we need to massage the fundus. So as you saw in that previous picture, you're holding at the suprapubis and you're massaging that fundus because we want it to firm. We want to make sure there is no bleeding going on. Okay. Bowel and bladder, you're going to want to make sure bowel sounds are good, but you're also asking, when was their last bowel movement? What's the consistency of that last bowel movement if it was recent? Okay, and they're in the postpartum period. Do they need some type of intervention? Typically postpartum, they're going to get stool softener like Colace twice a day. But also, can you guys tell me what's something that, we give people in the postpartum period, or that they've been receiving during pregnancy, that might create some constipation issues?
Iron.
Iron. Good. So what are some things that you might want to teach your patients in this period right now when we're giving care? What are some dietary things we want to tell them?
Fiber, increase intake of
Fiber.
fiber.
Or
Fiber.
liquid
Okay.
intake.
What else? Good. Fluids. Okay, that's good. So those are some good teaching things that we want to tell them. Just giving them a heads up, making sure that and this actually helps too if they're breastfeeding, making sure they're taking in enough calories, making sure they're taking enough liquids in, that they're doing what they need to do, to making sure they're having a bowel movement, making sure that they're making what they need to make for their child. Okay. Same with bladder. Okay. Are they urinating? When was the last time they urinated? And if they need assistance, if they still don't have their feeling in their legs, we can assist them. If we feel the uterus, and we do our fundal check, and we feel that the uterus is displaced to the right, and I know that sounds a little off. We're going to go into this a little bit more. If it's displaced off to the right, that can signify that they have a full bladder. Okay. What you want, the uterus needs to be at the umbilicus. So we all know umbilicus. You're going to use your fingers to determine the location of the uterus. Okay. So, as I said, typically in the immediate postpartum period, depending on the number of children that were born previous or at this time, they should be like one below the umbilicus or at umbilicus, okay? But it always should be midline. So if you see maybe to the right, you feel it's distended off to the right, figure out when she urinated last, empty the bladder, and reassess, okay? You might notice that fundus moved back midline. That's how it should be. If it still didn't move off midline, let's figure out why. Is she firm? Do we need to do something about that? If she's distended and she's off to the left of the umbilicus, that's more signifying of maybe some other type of bleeding going on. Okay. But again, we want to know, is she firm? Is the fundus firm? And we want to massage it as well. And if she's producing any type of clots. Okay, we're going to talk about that a little more right now. So the bleeding, we saw on the previous page where there was those pads. So we already talked about the amount. In the first few days after delivery, including the first, like the delivery day, you're going to have 3 types of drainage, okay, or discharge. The first one is called rubra, and rubra red or bright red blood, okay? And that's usually from day 1 to day 3. And I'm actually skipping ahead, but let me skip ahead. I'm so sorry. Hold on. I'm sorry. Here. So when we come to this, you guys have this. I'm going to allow everybody get to this page if you've printed them out previously. I apologize. Okay, so day 1 to day 3, it's bright red or dark red blood, and you can have some small clots. They generally don't want you, I'm saying they, as practitioners or, just in postpartum care, generally speaking, they don't want you to have any clots bigger than a quarter or up to a golf ball size, because that can be some type of retained tissue, or a large amount of blood being held in that we want to check on and see why. Okay. The next type of bleeding we have is serosa, which is in the middle here. And it's that pinkish brown, and it can last from postpartum days from 4 to 10. And again, these usually taper off in amount as well, as you can see to the picture. And it varies again from the amount of babies women have had too. So, but this is usually the standard of what we use as measurement. And then alba is the third. It's like a yellowish whitish discharge, and it's from days postpartum 11 to 21. Okay. Now again, if we're telling our patients on discharge or even after delivery, if they're having any clots like this, they need to let us know. I'm going to go back up here. I'm going to finish going over just a description of bubble heat, and then we'll go back down. I really do apologize. I get a little carried away sometimes. Okay, so any filling of pads, like 1 to 2 pads in an hour, need to be reported. Again, because it can be contributory to a bleeding episode that need to be looked into as far as like postpartum hemorrhage, or maybe retained placenta, which means part of the placenta tears away from the actual placenta and stays on the uterine wall. And we need to discover what's actually going on. Episiotomy or perineum. I kind of told my other students too that I use this as like extremities too, to keep a mind on your extremities if they're moving. But episiotomy is like the position on the side away from you. Okay. When you're looking at this and you're checking down below, of course, if you're taking care of REEDA, that REEDA that we went over earlier, you're going to check for hemorrhoids, which we know are going to be more in the rectal area. But when you're doing this also, you're down below and you're having them turn sometimes. Use this time to also look at their lower back. Okay. If they've had a spinal or they've had an epidural, this is a good time to look at that area, whether they have a Band-Aid on site or if they have, whatever the case may be, you can still look around and see if they have any edema, any ecchymosis, any redness, if they have any complaints, if there's any type of any type of swelling, if there's any bleeding coming from that, making sure those sites are doing well as well. Homan sign. And then the overall assessment of legs, edema, pulses, DTR. So DTR is your deep tendon reflexes. Everybody has a deep tendon reflex throughout your body. Okay, you have them in your elbows, your wrists, your knees. When the doctor takes the reflex hammer and taps your knee and your leg pops up, that's your deep tendon reflex. You have them in your ankles. Okay. So typically the nurses will check those to see if your neurological status is still intact. Sometimes electrolytes can affect that. So we want to make sure that they're not off or, insufficient. Edema, we know it's associated, and your pulses, that's kind of mainly all tied into your main head to toe assessment. Clonus is associated with kind of your reflexes. So it's where they take the foot and they check it. And if it's there, if clonus is there, the foot will tap. And it can be usually a sign of high magnesium levels. Magnesium levels is when we give like magnesium sulfate. Okay. But again, these are all assessments that we typically do of the postpartum person. Let's see, emotional status. I mentioned this earlier. We usually start this from the door, but when you come in and you build a rapport with your patient, you can get more into this. When you get a nurse-to-nurse report in the morning too, you're going to find out some information about your patient. And then you can kind of build on that. All right. So find out their needs, the baby's needs, and kind of assess what you can do. And if further consults need more. Okay. I'm going to kind of mention a little bit more about that in a minute. Okay. Involution of the uterus. So any changes in reproductive organs occur, and they're going to obviously eventually return back to a normal pre-pregnant state. Okay. Size and condition. They're never going to be exactly the same, but they generally come back to where they need to. It comes immediately after the delivery of the placenta. We start that contraction again. It's going to continue, but we give that Pitocin postpartum. So we want it to continue. We want it to contract back down. So the muscle fibers are contracting back down. You have the regeneration of the uterus in the inside. So everything that just sloughed off needs to rebuild. The site of the placental attachment heals by exfoliation. It's what it continues to do, and then will continue to do with further menstruation and all of the lochia that you've seen in the PowerPoint. Okay, so that's the way that the uterus rebuilds itself. So here's some more description of involution of the uterus. So subinvolution is when the uterus does not do what it's supposed to do. Okay, so it does not return to the normal size, and it can cause infection, it can cause a hemorrhage risk, and it can be due to retained placenta. Okay, so that's partially why doing a postpartum assessment of the fundus is so vitally important. We want to make sure the uterus is doing what it needs to do. Okay, so by looking at this picture, the uterus usually should involute back down 1 finger breadth a day. Okay, so by day 9, it should be sitting back in the pelvis where it needs to be. Okay, again, I usually say general rule, this is how it should be, but there again, how many babies has mom had during that one pregnancy, right? So if she had if she had twins or triplets in that one pregnancy, it might take just a little bit of time extra for that to occur. But again, this is just a general rule of thumb. Okay. Your fundal assessment is used to track involution, and it should be midline and at the level of the umbilicus. Okay. It should be no longer palpable above the symphysis pubis at 9th day. And again, what you're looking for is it should be firm. That means it's contracted, okay? And if it's soft and it's boggy, we need to massage, okay? Because that can be a sign of bleeding. Involution of the uterus you can sense that that's happening when you feel the after pains or the uterine contractions with delivery that happens postpartum. Okay, so when those who've had women, or good God, I can't speak, women who have had children in the postpartum period, when you've had your uterus checked, your fundal check done, and you feel your nurse do fundus check and it starts to contract afterward, it basically stimulated the contraction. So sometimes when you feel that and you feel the pain afterward, okay, that's associated with it. Also, when you're breastfeeding and women tend to say, oh, I feel like I'm contracting, it's because you are. So as I said earlier, the oxytocin and the prolactin occur with breastfeeding. Oxytocin. Okay, so the oxytocin with the prolactin, your oxytocin stimulating your uterus, so it's going to contract. Okay, so that's why they may feel the pain afterward. Ibuprofen and Tylenol are given postpartum to help with these pains. Usually it helps. Very rarely have I seen anybody have, need for anything else, but there again, everybody's different. C-section patients usually need a little bit of narcotic help after, because, we've cut into how many different layers of their abdomen, but again, everybody's different. And then the pain from this usually subsides by day 3 postpartum, but again. Fundal massage. So this is a good picture of what I was kind of explaining earlier. The muscle's going to contract to stimulate if boggy. A good gentle massage helps prevent inversion, because I know this is scary to think. If you're not supporting it down below and you go ahead and press here, think of all the trauma that just occurred with birthing that child. You do run a risk of involuting the uterus outside. I have seen it done once. It's It's very traumatic, but I mean, as long as you're doing what you're supposed to do correctly, good practice is good practice. So, this is fundal massage. Again, your picture of your lochia, how we just went over. And I apologize for skipping. I kind of get ahead of myself sometimes. So when you're charting your lochia assessment, again, you're going to say the type, what color it is, whether, say, if it's serosa, it's pink, small pink drainage, noted on pad, malodorous. If it's malodorous, it should not be malodorous. Malodorous means that it's bad smelling, okay? And that can signify infection. So, what I want you to keep in mind too, I know this has been spoken about in previous lectures, if we're checking lochia, if you're noticing different colors or different smells, and I know that sounds completely horrid, but if you're noticing something different than what we're describing to you in class, you need to notify the provider. Again, infection is real. During cervical checks, we try to keep it down to a minimum because of infection risk. Women get Foley catheters placed, or again, depending on protocol per facility, they might get straight cath. And if we're constantly doing straight cath, in and out, in and out, in and out, we're introducing bacteria. So that puts them at the high risk. And then again, the trauma associated with the birth. Also, if they've had a rupture of membrane, whether it be spontaneous or artificial, if it's greater than 24 hours, we're looking at a higher risk of, infection, okay, for them to develop a possible chorioamnionitis, okay? So we want to make sure in their lochia that it's not developing an infection, that they're not developing pain not associated with postpartum period and not some type of endometritis, okay? Some endometria, uterine, itis, infection. Okay, so we don't want an infection of the uterus, right? Okay, right here is table 20.1, more characteristics of your lochia. I believe this is from your book. It does break down a little bit more characteristics for you to go over. So consistency, color for you to review. Here's some more information in regard to breast care. Again, description. Mature milk will come in on the 3rd to 4th day. They'll start to feel very hard, hot and heavy. So we want to make sure mom is feeding that baby usually every 2 hours or on demand for that child. If mom decides that she wants to pump as well, and she is looking to increase her milk supply. She's planning on going back to work relatively soon. Sometimes lactation will come see her. Sometimes they'll, give her breast pump in the hospital, and they'll say, okay, you can pump, and, it'll help increase your milk supply. However the mom wants to do it, she's free to do so. But we want to make sure we're educating her on these things so that when she does go home, she understands the changes that's going on with her body. So this kind of goes more into what I already said, and I apologize. So having to express a little bit for nursing. This kind of gets the baby interested in a feed. So children, we know when they're infants, when they're really hungry, they get very fussy. But if we try to guide them where the food is, we can do what's called the rooting reflex on the child. So we can stroke their cheek, and they're going to go towards the food. They're going to turn towards the food. But in the same respect from mom, we can express the nipple and express milk out so that the baby can smell and sense the food. Okay, so that helps. And then down below, not stimulating to dry up the milk supply. So the vagina and the perineum and the cervix. So the cervix will generally kind of, it takes quite a while, probably up to about 6 weeks for it to close back up. It just takes a while. Women who have been multigravida are even grand multigravida, multip rather, may take a very long time or may still even be open, just a relatively small amount. So they're more at risk for like long term, even when they're not pregnant, for things when inserted into the vagina. We want to make sure that they're aware, you know, that's just to be aware that that can possibly happen. We just want them to make sure anything inserted can, for lack of better terms, get lost. So we try to tell them postpartum to not insert anything into the vagina up to 6 weeks. That includes tampons. They try to stay away from sexual activity for a period of time. Not that that's going to get lost, obviously, and I apologize, but you know, your risk of infection, your risk of getting pregnant, you know, things like that in that time frame can be greater. Okay, and you want the woman to heal. They need to have that healing time. Okay, so small tears or lacerations can be present, very edematous, and again, painful. Healing can occur by the end of week 1, and it can end up forming like almost like a callus, and it'll feel firm. There is an internal and an external Oz. You don't need to know that, obviously, but it usually is dilated to 1 centimeter. Vagina, 6 to 10 weeks to regain non-pregnant size and contour. It will never regain the size it was prior to being pregnant. And then the perineum, edematous and bruised, as we said. Going over the Rita assessment, trauma. Okay. Episiotomy or lacerations, even like lacerations down into the rectum, those can be extremely painful. And we need to teach these women about care for those, because if they strain to have bowel movement or those sites separate, okay, they can bleed and they don't know where it's from. Okay, especially if they're a little bit more obese, they don't understand. But either way, the healing for that can take up to 4 to 6 months. So as we're doing these things, as we're caring for these patients, I honestly, I say this all the time, but teaching is of the essence. And I want to say too, for perineal care, we try to tell these patients or explain that using the sitz baths, so it kind of looks like I don't know if some of you know what a sitz bath is, but it looks as if it's a big, mind blank. Like a
little basin.
Thank you. But you're sitting on it. And in the back, it has the hole like for an enema. Okay, so it has the like a 1,000 milliliter type bag that's attached. And you can take that part out, but you'll fill it with like lukewarm water or whatever is substantial for that patient. And you can like slow it or make it faster by clamp. And it'll run into that hole and it'll shoot into the perineum. Not shoot, but you know, it'll be aimed at the perineum and it's going to cleanse and soothe that woman. Okay.
It's like a
I've
little
actually
bath
put
day for your perineum.
correct. I've actually put like liquid witch hazel into it before, mixed it with warm water, and that seems to be kind of nice for them too. In the hospital too, we have what's called Dermaplast spray, and it's even over the counter. So when they're discharged and you can let them know, hey, we're giving you this can of the Dermaplast so you can spray it on yourself, or you can spray it on your pad to help numb the perineum. It's got like a lidocaine in it. It's available over the counter, so if you feel that it helps you, it is available in the pharmacies. That's an option. Witch hazel or Tux pads are also available to them to help soothe the perineal area. And then they have those spray bottles that we try to just fill with water, tap water at the bedside and when they're in the bathroom. So when they're done urinating, we can spray them off. And that helps. It's like a nice soothing thing as well. I always like to take baby diapers and put like little, because the hospital ice is amazing. So you open it up and you put some ice in it and you shake it down and you re-tape it down and you make it nice and flat and throw them in the freezer, and you can make these nice ice packs for the women, and they're super absorbent because it's a baby diaper and it's got the ice in it, and it's a nice ice pack for the women, and you put it in their you know, disposable underwear, and it helps them and it soothes the perineum as well. So you can get really like crafty with some of the things you do for these women, but it, you know, it helps them in the end. Here's another little table from your book, lacerations of the birth canal. They can go from 1st to 4th degree, just depends on how deep or the location that it goes into. So here, you know, 4th degree goes into the rectal area, okay? So again, these are areas that need sutured by the provider at the birth, okay? Usually, if, you know, I know there was a girl we saw at clinical yesterday, she opted not to have a epidural, and she did wonderfully, first baby and everything. And afterwards, she didn't have any lacerations, but, you know, that's one instance. Then we had another girl, she had an epidural, and practitioner decided, you know, she did have a laceration. Sometimes, if the epidural is still working good enough, they don't need to numb the perineum. Sometimes they do, because epidural may not necessarily be affecting the perineum for that. It's usually to help the mom get through the contractions, and then they'll birth. So lidocaine is used to numb the area, and then they'll do the repair for that. They'll also, you know, use iodine solution. They'll pour it over the perineum to cleanse the area, and then they'll go ahead and repair. Okay. Anybody have any questions right now? Just want to make sure that check. See. Megan, yes. I'm sorry, I feel bad that I'm missing these. Thank you, Megan. Okay. So here's pictures of the 1st, 2nd, 3rd, and 4th degree lacerations. Yes, they can be as traumatic as they appear. But again, this is why we have all the interventions in place for our patients. Excuse me. And why we try to cut it off at the pass, so to speak, pardon my pun, for women who have constipation. Okay, because as you can see, a 4th degree laceration can be quite extensive. Okay. So here we have cardiovascular care. As we talked about previously, your cardiac output increases, but your RBCs don't. Despite the blood loss, you know, you have a transient increase in maternal cardiac output occurs after birth. Okay, our excess plasma volume accumulates during pregnancy and then eliminated by diuresis and diaphoresis. So diuresis is, of course, the urination, and diaphoresis is how we sweat or breathe. Okay, gradually, cardiac output decreases and returns to normal in 6 to 12 weeks. So you can see how the postpartum period can be just, it takes a while for the body to kind of reacclimate itself, right? So getting everything that we need to do, and for the body, like the nutrition, the you know, intake, our output, and everything that we do in that maternal postpartum period is so vitally important. And then here, coagulation. Increased clotting factors predispose the woman to postpartum clot formation. Mind blowing, right? So again, the H in bubble he, vitally important. Okay. And then you got to think too, sometimes you have women that come in that have previous blood clots or factor V, or, you know, sometimes bleeding disorders altogether, you know, so we're always assessing this. Our GI system. So after childbirth, we have an increased hunger due to the energy expenditure of labor process and birthing. Again, start slow, make sure they're not having increased nausea and vomiting. And we're addressing the constipation, doing all of the things to cut it off. The decreased muscle tone, bowel tone because of the progesterone during pregnancy. Again, it's going to be sluggish for the first few days, but it's going to increase because, as I said earlier, the estrogen and the progesterone kind of shut down. Okay, so it's going to return to normal. The fear of the pain during defecation is mighty. So again, doing all the things. The first stool 2 to 3 days postpartum returns to normal after days 8 to 14. So even letting them know that the Colace is over the counter after this and not something that they need a prescription for, let's give them a sense of relief too, trust me, because a lot of these people don't like, it's a very trying time for them anyway, even if it's their first baby. Like, oh my gosh, I have this whole human being I'm taking home to take care of, and what else do I need to do to take care of myself? And we're giving them this, and this, and you know, more to fall at their doorstep, right? So the most we can give them information or written information on what to do to take care of themselves or their child, the better off they're going to be in the long run. Okay, so giving them the information and helping them make those decisions. Urinary system, increased bladder capacity, decreased sense for fluid pressure may result because, again, all of that trauma down below might change things, okay? So increased risk for infection. You've had all that down there. You're going to have an increased risk anyway, but we want to make sure we constantly have mom try to empty her bladder at least every 1 to 2 hours. Okay, the urinary system must handle increased load in the early postpartum period as the body excretes excess plasma volume. So output versus input. Okay. As I mentioned, the trauma to the lower urinary system during childbirth takes a good hit. So the pressure of the descending fetal head on the ureter's bladder and urethra can lead to transient loss of the bladder tone and urethral edema. The distended bladder displaces the uterus, which can interfere with the uterine contraction and can cause excess bleeding and hemorrhage. I hope that makes sense to you all. So, you know, everything gets cramped in there, and then how do things work together? Do we have enough? Does it have enough room to do what it needs to do? So, are we clotting like we need to? Right? So, are we bleeding too much? Are we bleeding enough? Like, constantly assessing these people and their bleeding, and if they're, you know, urinary status, all of that, is it adequate? Is it what it needs to be? Vitally important. Okay. So here's a picture here of the bladder, and if you think the fundus is up at the top here, okay, where that shadowed area is. So think about that. All that pressure, we want to make sure that they're emptying their bladder. Very important. Okay. And that's when I mentioned earlier having that right-sided bogginess. This is because it's displaced, right? So empty that bladder. Here's another table from your book, the signs of the distended bladder. Okay. Your extremities. So we want to check for the return of feeling or, the making sure that the regional anesthesia has kind of worn off, making sure we're checking for varicosities, checking those deep tendon reflexes, checking for the clonus, that edema, the pretibial or pedal. Does anybody, I'm going to ask this question, does anybody remember what Miss Megan said was one of the signs of preeclampsia edema that you need to be watching out for? Let's jog that memory.
Face swelling.
Very good. So sometimes if you see periorbital or around the eyes, periorbital edema, we need to be aware of that. We need to watch and let that provider know. Very good.
Is headache one of it?
So yes, headache is one of the signs of preeclampsia, but I was just going back to the edema. So,
Edema, okay.
sometimes, the edema. So if some types of normal edema you might see is in the lower extremities, but one of the bad signs of edema that we really want to make sure we're checking for is if you see it in the face. Okay, because that might be more telltale of like preeclampsia. You might have a little bit normally in the legs with pregnancy, but if it's to a very substantial amount with its pretibial or pedal, that could be more increased along the lines of preeclampsia with other things like the hypertension and the other like labs and stuff. But if it's like in the face, that's one of those really, really bad signs we need to look out for. Very good. Risk factors for thrombosis or for clotting. So if they are obese, if we had significant varicosities, so if they have those veins that are just like those little spidery looking things, okay, we'll look for that. Anemia, surgical intervention, and a traumatic delivery. So surgical intervention, we know is a cesarean delivery. Traumatic delivery. So I know in a clinical, we had heard about one of the babies previously had been born with forceps, and it was a vaginal delivery with forceps. The provider went in, grabbed the baby, and it was shoulder to shoulder, okay, because it was a shoulder dystocia, and ended up fracturing both clavicles, okay. Those types of deliveries, whether it's the traumatic delivery like that with the dystocia, whether it's a surgical delivery intervention with forceps, something like that, those are risk factors because of certain things like that being introduced. So signs to be aware of are your pain, your redness, your heat, your swelling, and that positive Homan sign. So that Homan sign, again, to recap, when you dorsiflex the foot or you put your toes to your nose, right? Not saying figuratively, but you dorsiflex, you pull that toes to your nose, that's your Homan sign, okay? So DVT prophylaxis or prevention, walk that patient. So as soon as the paresthesia wears off, you want to make sure if they're able to handle it and they're not lightheaded or dizzy and all that is okay, we got to get these people up walking. Okay, we don't want them to be any more at risk for DVT than they already are. Okay, making sure they're circling those ankles while they're laying in bed, and increasing all those, and don't cross your legs. And when they have their blood pressures taken in bed and they're in the hospital, make sure they don't have their legs crossed, because that can increase and make a non-accurate blood pressure as well. Musculoskeletal system. So we're looking at those muscles and joints. First 1 to 2 days after childbirth, the muscles are fatigued and ache, whether it's in the shoulders, necks, and arms. Sometimes they might feel it in the sides of the hips because of all of the maneuvering going around for childbirth. Your abdominal wall. In previous slides, you were shown what diastasis recti is, which if you recall is that separation of the rectus muscles during pregnancy, whether it's minimal or severe. I know Miss Megan showed you that picture of, I believe it was, you said it was yourself, correct?
Yep, that's my belly, or was my belly.
And so, you know, we want to make sure that usually resolves within 6 months. So gentle exercises can help. Reduction in musculoskeletal discomfort. So again, those exercise to strengthen the abdominal muscles, usually using those Motrin or the Tylenol that providers offer, and using good posture and body mechanics help as well. So here's that picture of the diastasis recti, as you previously were seen. Our integumentary system. So our skin, does it gradually return to a non-pregnant state? Diaphoresis, so that's sweating or the moisture on the skin, occurs in the first few days after childbirth. Night sweats are common and can last longer in breastfeeding. So sometimes we're expending more energy, so we're going to have that natural release in energy, and it's going to come through the skin. Estrogen and progesterone and melanocyte stimulating hormone, which cause hyperpigmentation during pregnancy, decrease rapidly after birth, and the pigmentation begins to recede. So you're going to have change noticeable, like the melasma and the linea nigra. So melasma is that mask, MM. Okay, the mask of pregnancy. And then that linea nigra is that dark line of the abdomen, tend to fade or disappear for most patients. And then the striae gravidarum tend to fade into like silvery lines, but they don't usually completely disappear. Neurological status. So again, complaints of headache, you need to be careful with this. If it's bilateral and frontal, they're usually common with the fluid and electrolyte changes that occur. Spinal headaches can occur, but the most prominent ones that we're worried about are the ones with the blurred vision, the photophobia, where the light sensitivity occurs, and that right upper quadrant pain. So that epigastric tenderness that I was talking about might indicate that preeclampsia. Okay, so those are some things that might indicate, hey, we need to tell the provider what's going on. Do we need to get some other things going on as far as like lab work and stuff? Our endocrine system. So again, the hormones, you know, readjusting themselves. Our HCG tends to be elevated for the first 3 to 4 weeks, and then it starts to die back down. Resumption of ovulation and menstruation will eventually start to kick back up. Breastfeeding, again, like I was saying earlier, might delay the return of ovulation and menses because of the hormones that are produced, okay? Your ovulation may occur before the first menses. So again, this is where we need to be careful, and we need to educate these patients. They should not use breastfeeding as a reliable method for birth control, okay? This is why. And the same with, you know, the timing method. The timing method relying on menstruation, okay? Using something like the basal body temperature, wonderful, because you're checking their ovulation time. Lactation, again, prolactin remains elevated in the immediate postpartum period, and will usually stay and initiates the milk production. Here is a video that goes over a postpartum postpartum assessment throughout. Highly recommend that. I know you guys will be getting tested off in that in lab. And we will be going over that in lab. I don't expect you to be just, you know, osmosis. So, weight loss. So We know our fat tissue is adipose tissue, and that's used for energy expenditure for both labor and breastfeeding. So you use a large amount of calories for using energy. You have approximately 12 pounds lost during the whole childbirth experience between the fetus, the placenta, and the fluid. And then another 9 pounds is lost over the following 2 weeks. Okay. And then in the next 6 months after the delivery, you lose another 5 pounds. Okay. So just consider that. This is on average. All right. Risk factors for postpartum hemorrhage. I would think this is a very good slide to definitely go over, guys. A grand mal to parity is somebody who has had more than 5 children. Over distension of the uterus with a multiple pregnancy, with twins, triplets, quads, something like that, puts the uterus at risk for rupture and can lead to a hemorrhage. Any type of retained placenta. So when the placenta separates from the uterus, it has potential for leaving a part of the placenta to the uterine wall. Placenta previa, where the placenta kind of comes down and it covers over a portion of the cervical os. So the cervical os is the opening of the cervix that comes down into like right over top of the vagina. Okay, and that's the part that we feel that is dilated when labor and delivery nurses do cervical checks to see dilatation. Okay, so on the inside, because you have an internal and an external, the external is what they check. Okay, the internal is what we're talking about with the placenta previa. So if it sits low lying, close to it, or even directly over it, makes a risk for a hemorrhage even greater. So if you think about this, as the uterus grows, it's growing like this. So that cervical os, as it goes, and somebody is getting ready to deliver and they start dilating, as they start to dilate, it's making that opening, right? So if it's making that opening, it's going to make them at risk for a rupture of that placenta or that area, and they're going to lose blood. Okay. And then abruptio placenta, it's where the placenta actually detaches from the uterine wall. Okay. So again, that's completely like separating away, and you're going to get a large amount of blood. Medications like tocolytics. So again, toco contraction, lytic to stop or slow. So we want those can possibly create that. And then oxytocin stimulates contractions. So if something is stimulated to contract and it's over or hyperstimulated, it can be too much and create more of a hemorrhage. Operative procedures like a cesarean birth or the vacuum extraction, those can lead to bleeding, and as well as preeclampsia or like some type of coagulation defect. Risk factors for, intrapartal infection. Again, operative procedures, because again, they're invasive. So cesarean section, vacuum or forceps deliveries, and episiotomy. If they've had multiple SVE, so that's spontaneous SVE. Is that supposed to be cervical, vaginal, or cervical exam? I would think it's supposed to be cervical exam.
Sterile
If they do
vaginal exams.
sterile vaginal exam. Okay, so sorry. So sterile vaginal exam. So the more times we introduce our any type of something from the outside, you're introducing possible bacteria. So the more times we check somebody, the more times you're introducing bacteria. So if somebody's complaining of pressure, if they're complaining of pain, if they present to labor and delivery with contractions and they're, we need to at least get a baseline, you're going to do that, but you want to keep it to a minimum. Okay. Prolonged labor, ruptured prolonged membrane rupture, the manual extraction of the placenta where they need to go in and clean it out, any diabetes or catheterization. These all give more risk for infection. And then, you know, we want to make sure they're clean, keeping pads under them, linens as dry as possible, and then eliminating anything that's been moist for a long time. Like when they continuously have, you know, amniotic fluid rupture come out, we want to get that out. Providing care measures, all the things that we've basically mentioned already. The donut pillow is good for any type of, you know, the hemorrhoids and episiotomy, tailbone that can happen too because of how baby comes down. Pain management. I even mentioned these things already, so again, I apologize. And then becoming acquainted. So we want to bond. We want to bond with that baby. Initial attraction. Both parents or both the both if it's the mom and the
Caregivers.
partner. Okay. Yes. Sorry, Megan. I'm like, English is not Englishing. So if they're separated within like the first hour or two, it can be a little harder for them. It's that golden hour of time. So sometimes we like to do skin to skin as soon as possible. It's easier with vaginal deliveries, C-sections, you know, we try to get them sewn up and brought to the recovery and do skin to skin as soon as possible. But it's that good bond that they get right after the birth. And then we want to promote that bond. We want to promote that attachment. So if they want to start feeding, if they want to do, you know, face-to-face position, if they want, you know, that's what we want to facilitate for them. This is from your book for you to review. And it says as well, postpartum blues. So this usually happens within the first 2 days of delivery. Baby blues is what it's called. So it's like a mild depression that is transient and self-limiting. It usually comes in, it will dissipate by itself. Thought to be related to hormone fluctuations after childbirth. 70 to 80% of mothers have this. Can be up to the first week postpartum, and it should not last longer than 2 weeks. Okay. If it lasts longer than 2 weeks, then we're maybe looking at some type of postpartum depression. Okay. And then it can be longer lasting sadness, feelings of self-harm, feelings of wanting to harm the baby that last at least 2 weeks or more. They are unable to feel pleasure, love, able to care for herself or her infant. And then you have, you know, experience generalized feelings of fatigue, irritability, lack of interest in food, sleep, or, you know, basically things that sustainable for, you know, you to actually like live, you know what I mean? Psychosis I've seen where people end up, it gets to the point where you need to get a provider involved for like a psych evaluation, where people typically will like look off into the corner and they'll start talking to something that's not there or somebody that's not there. You know, that's something that, like I said, needs to be intervened on, because we don't want them to not have an intervention that's necessary and then go home and cause harm to either themselves or their infant. Postpartum immunizations, and again, this is for mom. We have the rubella, which is your part of your MMR, and it's safe for the nursing mothers. Side effects are your transient rash, fever, and any joint symptoms. They need to sign consent for this, and it is good contraception. You need to use contraception for 3 months with this. You need to RH, your RhoGAM. Okay, so if mom's RH negative and the infant ends up having its cord blood run and it comes back Rh positive, that means mom is lacking the antibody that it needs. Okay, so if their blood mixes, whether it was intrapartal or, during delivery or something, she needs to be given the rhesus factor or that Rh factor to prevent her blood from forming some type of I'm like having a moment right
Antibody.
now. Thank you. Oh my God, against the blood. Okay, so that she does not have any type of disorders in the future. Okay, so it's usually 300 micrograms IM within 72 hours of delivery, and she also receives a dose of it intrapartal prior to delivering. We also give them a card to have with them in their wallet in case they have some type of accident where they can show that they've had that. And then the discharge teaching, the care of herself and the baby, goes over feeding, perineal care, her personal needs for nutrition and rest, medication needs and concerns, hormonal things like postpartum baby blues and things that she can expect, and then danger signs as well. So if she feels like she wants to harm herself or the baby, if she has any visual disturbances, if she has a headache, if she has, any of the things that we said were danger signs in our postpartum here, those are things that she needs to call her provider about because she needs to have some type of intervention. No sex for 4 to 6 weeks. Contraception options if they're considering contraception, and a postpartum follow-up appointment with their provider. And that covers postpartum.
There was a question in the chat. Just to clarify, so MMR, the vaccine, is not a form of contraception.
No.
What it's saying, sorry, I probably should have been more clear when I typed this out, but basically the mom needs to use a good form of contraception in those 3 months after receiving that vaccine because you're not immediately immune. And
Correct.
rubella, if you are exposed to rubella in early pregnancy, like you've never had a vaccine and you come into contact with rubella, which is German measles, it is known as a torch infection. So it is something that we know is a teratogen. Remember, teratogen is something that we know can cause issues with fetal development. So if that mom were to get pregnant right after receiving the MMR, she does not have full immunity. So the effects of being exposed to rubella could still affect that developing fetus. After 3 months, that vaccine has had a chance to take full effect. And so now if she were to be exposed to someone who has rubella or German measles, she's good because she got the vaccine. Does that clear that up a little bit? Okay, good.
Sorry.
All right, no, that's fine. No, they're my slides, and so I just know what I mean by them. So I could definitely understand if somebody else is reading them. They're like, wait a minute, that's not one of the contraceptives that we talked about. And you are correct. It is not. Do not use that as your form of contraception or you will become pregnant. Okay, does anybody have any questions about postpartum care?
When do we give the Rogaine?
Rogam, not Rogaine.
I know.
Rogam. I know, they're
Hair
kind of
growth.
similar. So basically, and I think I talk about this a little bit in the newborn at risk as well, but so, we all have our blood type and we're either Rh positive or we're Rh negative. Moms that are Rh negative means that they don't have that little protein, that Rh protein on each one of their red blood cells, which is fine, not a big deal. But when we talk about pregnancy, it can become a little bit tricky because we have created this whole other baby, this human inside of us that has its own blood type. And the baby's blood type could be Rh positive. If Rh negative and Rh positive blood mix, then that can be dangerous because that mom's that mom's negative blood type will see that positive blood type as like a foreigner, like an enemy. So it will create these antibodies and it will start attacking those fetal red blood cells, causing them to lyse and to break down. And then that baby can obviously become severely anemic. And we'll talk about something called erythroblastosis fetalis, which is that process where mom is attacking those fetal red blood cells. So to answer your question, we have this wonderful immunization that we can give called RhoGAM. RhoGAM prevents that mom's body from creating those antibodies. So it basically like coats those fetal red blood cells and hides them from mom so she can't see them. She doesn't recognize them as a foreign blood type, and so she never creates those antibodies. So is it any type of positive? Yes. So any negative and any positive should not mix. And I know we talked about how in pregnancy, mom and baby's blood really shouldn't mix, but we know that there are scenarios when that can happen. Trauma, like a big car accident or some kind of like trauma with mom, or just it can just happen. Very small amounts. All it takes is a very small amount for mom's immune system to detect this foreign invader, basically. And then it starts that process of creating those antibodies. So with that woman's first pregnancy, if she's an Rh negative mom, and that baby happens to be Rh positive, and she recognized that, she creates those antibodies. Antibodies take a long time to be created and to make enough of them. So usually that first baby is unharmed, but it's the subsequent pregnancies, like if she never got RhoGAM, she gets pregnant again, she already has those antibodies circulating in her bloodstream. So when this next baby comes along, and maybe that baby is also a positive Rh blood type, those antibodies will all start attacking those fetal red blood cells immediately. And so that's really when the issue is, not with the first pregnancy, the subsequent pregnancies. But as long as she receives RhoGAM, it prevents that from happening. Sorry, that's a long-winded answer. So anybody with an Rh negative blood type gets RhoGAM at 28 weeks pregnant, when they're pregnant, because we don't know the fetal blood type yet. And so they get RhoGAM just in case. And then like Ms. Nicole was saying, after birth, they will get a sample of the baby's blood and they will check the baby's blood type. If baby is found to have an Rh positive blood type, mom will receive another dose of RhoGAM. If baby's found to have a negative blood type, we don't need RhoGAM. So we're good. She doesn't get any more. But if it's positive, she needs that RhoGAM again for coverage. Does that clear that up a little bit? Is the vaccine a one-time thing? Like she gets it? So no, you would get it with every single pregnancy because it's a new baby with a new blood type. Any other questions?
Yeah, I wanted to ask, so if both of the mom and the baby, if they are negative, they don't do nothing, right? Or if they are the
Right.
same positive. Okay.
Right, but still during her pregnancy, because we don't know that that baby's negative, she will still get that dose. So everybody who's negative gets at least one dose of RhoGAM at 28 weeks gestation, but that second dose, that postpartum dose, she would not get now that we know that the baby is negative. Good question.
Okay.
You will also get RhoGAM throughout pregnancy if you do have something traumatic happen, a car accident, a fall, if that pregnancy ended in a miscarriage or abortion, because that baby still existed in there. So you would get RhoGAM for those particular circumstances as well, or any kind of invasive procedure, like if mom has to have that amniocentesis where they put that needle through her abdomen, that's an invasive procedure. So that's a procedure where blood could possibly mix, and so she would get RhoGAM for that as well. So every birth they test the placenta, blood, and arterial gases. No, not every birth. If mom is Rh negative, yes, that baby will get cord blood. So they take a sample of the blood from the cord. If mom is an O blood type, they will also get a sample of the cord blood, because we'll talk about how O blood types also can cause a little bit of issues. I'll talk about that, so just hang tight on that. And then arterial, like blood gases, typically are only collected if there's something traumatic going on with the delivery and they're trying to gain some more information about if the baby could be compromised. So they want to see the pH and all of that. So we will get a sample of the venous, the vein, the venous portion of the baby's cord, and then the arterial portion. But not every birth gets that. Okay. Whew. Any more questions? These are good questions, guys. Okay, I think we all deserve a break. So let's take a little 10-minute reset, come back here at 11:15, and then I'll go ahead and do those newborn chapters.
Thank you, guys.
Thank you.
Okay, guys, we're going to go ahead and switch over to newborn stuff now. Anybody have any questions before we get started? All right, let's do. All right, can you guys see my PowerPoint there?
Still voting. Yep.
Okay, I think I'm back. Can you guys hear me?
Yes. Can we go?
Okay. Okay, sorry. My internet's kind of been going in and out with the wind, I think, so I'm a little bit nervous, but hopefully we can get through this. Okay. I guess if Nicole, if you're back, just text me if the internet stops, since I'll be on a different screen. I won't be able to see if people are sending messages, okay? Hopefully I hold strong here. No sound. Ah! Can anybody hear me? Oh, okay.
hear you.
Okay. Can anybody else hear me?
Yeah, I can hear.
Nicole, that's just you, girl. Okay. All right, well, I'm gonna get started. Okay, so chapter 17, we're gonna talk about newborn transitioning. So obviously we've kind of gone over this, but newborns undergo a pretty rapid transition, like immediately after birth, the second they come out and they take that first breath. So this, from a nursing standpoint, requires very close observation. We are going to complete quite a few things in that first hour to 2 hours after that baby is born. And typically those first 2 hours are still under care of the labor and delivery nurse. So we, as the labor and delivery nurse, not only have our mom as our patient, but we now have a newborn as our patient. And we might also have another mom and another baby. So it really just kind of depends on where you work and how they do that type of like care. Like sometimes it would be another nurse, but a lot of times it's the labor nurse because it is such a high risk time period. So anywho, for someone like me, like I love labor and delivery. I love taking care of moms. And I love babies, but I don't like taking care of babies. It makes me very nervous. So I don't really love those first couple hours of having this newborn to take care of. I prefer my babies in utero, but that's just me. Okay, so in that first hour, Miss Nicole had mentioned that's called the golden hour. That's when babies are really alert. And so we really try to work on that bonding. So we do skin to skin as long as mom is up for that. And then we do try to initiate that first feeding, either breastfeeding or bottle feeding. We also give a couple of medications during that first hour. We'll go over that. And then, of course, we're always maintaining safety. Okay, so pulmonary transition. So we all talked about in utero how we needed those lungs, those fetal lungs to develop, but they didn't necessarily need to function. Well, now that the baby is being born, those lungs now have to function. So we no longer have that placenta to do all that work. So that first breath that that baby takes is what kind of it has this like cascading effect for all of these really quick changes. So pressure changes will cause that diaphragm to descend a little bit, allow those lungs to fill up with air, and then hopefully we have that exchange of oxygen. We also have the baby experiences hypercapnia, hypoxia, and acidosis, which all stimulate the baby's brain to initiate those respirations. And then we have a lipoprotein called surfactant that babies make throughout pregnancy. The further along they are in pregnancy, the more surfactant they have. So a term baby has more surfactant than a preterm baby. That surfactant is what helps keep those alveoli sacs open, and so they're open for gas exchange. And so that's why our preterm babies struggle way more with the respiratory transition. Production of surfactant starts about 26 weeks. So we all know that babies can be born before that. We can have these micro preemies born at 23, 24, 25 weeks. So it's obviously those babies need a lot of care in the NICU. We also can give a medication to mom if we know or we suspect that she's going to deliver early. We can give her those steroids, that Celestone or betamethasone, and that actually it's an injection that mom would get 2 of those injections, and it helps to expedite that surfactant production for the baby. And then in utero, those lungs were filled with fluid. Now we need to get that fluid out and fill with air instead. Once we do have established respirations, they are typically shallow, kind of irregular, and a normal respiratory rate for a newborn is somewhere between 30 to 60 breaths per minute. All right, and then our cardiac transition. So pressure also changes in the heart. So we have pressure in the right side of the heart that falls, and then we have pulmonary venous return to the left atrium that increases. So that pressure change is what allows that foramen ovale, which was one of those fetal shunts, the one that was located between the right and the left atria. It now shuts, and that allows the heart to function like a normal, like adult heart. There are scenarios where that foramen ovale can't stay open, and we'll talk about that when we get to our like newborn at risk chapters. Those other 2 shunts, the ductus arteriosus and the ductus venosus, close shortly after birth. And there are obviously scenarios where those don't close as well. All right, thermoregulation. So our normal axillary temp is somewhere around 97.9 to 99.7. Depending on the source that you look at, you may see a little bit different numbers. So I know for my students, I won't ask you like a specific question about that range, but you need to know like the relative range that you can identify a baby who is too cold or too hot. Hypothermia is typically less than 97.0. Babies do lose heat very, very easily. They have a large body surface area in relation to their weight. They also have very limited fat stores, so they don't have great insulation, especially the more preterm a baby is. Term babies have more flexion, so they can pull their limbs into their trunk, and that helps them conserve heat, whereas preterm babies are a little bit more floppy. They don't have that really good tone, so they also will struggle more with thermoregulation for that reason. And then they have just kind of limited capacity for heat production. So we all are able to shiver, and newborns cannot shiver. So they have something called brown fat that they use to break down to produce heat. So this is brown fat here. It's really only present in newborns. It gets replaced later on by our normal like white fat. It's deposited in the last few weeks of pregnancy. So once again, our term babies are going to have better temperature regulation than our preterm, because our preterm babies are not going to have that brown fat, or not as much of that brown fat. It's distributed around the scapula, kidneys, adrenals, head, heart, and great vessels. It is a very vascular tissue, and it accounts for about 2 to 7% of that newborn's weight. The process that kind of it breaks down, it converts this chemical energy directly into heat when activated by the baby's sympathetic nervous system. So it doesn't produce shivering, it just breaks down this brown fat, and that in itself will produce heat. All right, let's talk about some methods of heat transfer. Usually there's 1 or 2 questions on your exam or like ATI about this, so I would just review this. So we can have evaporative loss, conductive loss or gain, convective, or radiant. So we'll talk about those different kinds and examples. So ultimately, we would like to avoid our baby being too cold or cold stress, or too hot heat stress. Neither one is good. Both can cause issues with a lot of different things, but respiratory distress. We want to keep a neutral thermal environment the best that we can, because that's what is going to minimize our baby having to use their oxygen and glucose for inappropriate things. We don't want them to use those resources for keeping their body temperature. We want it to use for growth and development, things like that. Okay. So let's talk about those 4 different types of heat transfer. So conduction is when we have direct contact, because conduction is direct contact. So transfer of heat from object to object when they are in direct contact with each other. So I want you to think like if we take our baby who just has a diaper on, no clothes or anything, and we have just pulled this scale over that was maybe next to the air conditioning unit, and so the scale is cold, and then we put the baby directly on that cold scale, or maybe like a procedure surface. So I think of like if this baby's having a circumcision, there's a board that we put them on, maybe that board is cold and we put this baby directly on there. We try to line the procedure surface with warm blankets, or we try to put a warm blanket on the scale and then re-zero it and put our baby to try to prevent this type of heat loss. Convection is transfer of heat from the baby to cooler surrounding air. So if we had, like if baby's at home and the window is open, or we're next to the air conditioning, obviously they can lose heat that way. Evaporation would be loss of heat when a liquid is converted to a vapor. So when babies are first born, they are very, very wet. They're covered in all kinds of different secretions and blood and amniotic fluid. And so that's why one of the very first things that we do is we cover that baby with a warm blanket, and we switch out our blanket so we're not just continually putting a wet blanket on them. So once that one is wet, we get rid of that, we grab a new one. Or after a bath, that baby's first bath, obviously they're wet, so we're going to use warm blankets and try to keep them dry and covered as much as possible. And then radiation is loss of body heat to cooler solid surfaces that are in close proximity. So they don't actually directly touch, but let's say like if you're in your labor room, most facilities have like a little like a crib, a portable little crib. Maybe that was left over by the air conditioning unit. Mom was holding baby and now she's ready to take care of herself, whatever. And she puts baby into that incubator, but the walls of the incubator are very cold from being next to the air conditioning. So that would be an example of like radiation heat loss. Okay, so cold stress, what kind of happens there is baby's respiratory rate will go up. So we see tachypnea, so that would be greater than 60 breaths per minute. You may hear some grunting from the baby. It's a very distinct sound that they make. It almost sounds like they're singing, but it's grunting, and it indicates respiratory distress. You may see flaring, so their little nostrils can flare out, or you might see some retractions on the chest where their skin is pulled in between their ribs, so that's retractions. That all indicates respiratory distress, or just lethargy, like they're just not active and alert. And this is just from your book here to kind of tell you what's happening in the body. So when an infant is stressed by cold, we have that oxygen consumption that increases, pulmonary and peripheral vasoconstriction occurs, and then we're not getting as much oxygen to the lungs and to the tissues. And then we have this anaerobic glycolysis that increases. So we're breaking down the wrong things there. And that leads to increased PO2 and pH, which ultimately will make our baby acidemic. So metabolic acidosis is the end result of that process. So ways that we can prevent hypothermia. So we dry our baby, we remove those wet blankets. We put warm blankets, nice dry warm blankets on them. We put a little hat on them. We try to avoid placing our baby on any kind of cold surface. We try to avoid placing them in any drafty areas. We can use a heat source like a little, what are those called? Like an incubator. Most like labor rooms, when babies are born, we will pull in like an isolette or incubator that has a heater on it. So that will be in there. We're going to try to delay that initial bath until, we've had several temperatures that have been normal. Everything has kind of stabilized. If the temperature is not stabilized, then we could use that warmer, and we could put multiple warm blankets, and we've got all kinds of little tricks for that. And then kangaroo care. Kangaroo care is just that skin to skin contact with mom, dad, or another caregiver, because then they can be in direct contact with someone who's nice and warm and toasty. And then we cover the baby's body with some warm blankets, and that actually heats them up really well. So the opposite would be heat stress. So this would be a temperature somewhere around 99.5 or greater. Usually this is caused from like overheating, like people will they've got a big fuzzy hat on, and then they wrap the baby in the hospital blankets, and then they also have this fuzzy blanket that they bring from home, and then they're also holding the baby, and then the room is hot. So that can definitely also happen. So how that looks for our baby is that can increase their heart rate, it can increase their respiratory rate, they can become dehydrated, hypotensive, tachypnea. I don't know why I have that on there twice. They can have apneic episodes, flushing, sweating. They can have that decreased tone and may even have like a weak cry. Okay, and then our metabolic transition. So once again, we no longer have that placenta to provide that baby with all those nutrients and just kind of do everything for them. So now we need to feed our baby. So blood sugar, the baby's blood sugar reaches its lowest point in about 1 to 3 hours after birth. So that's why it's really important that we initiate that first feed within the first hour. Normal glucose for a baby is somewhere greater than 40. Depending on what sources, you may see this as 50. I'm not going to give you a question that's directly for that number because it depends on what sources you look at. So just kind of a general idea there. Glucose does stabilize by about 4 to 6 hours after birth, and these would be for babies that were not born to mothers with gestational diabetes. So those babies have more issues, or a really large baby or a preterm baby. Some baby that has some type of condition that could compromise them is not going to stabilize as quickly, but normal baby, it's about 4 to 6 hours. Something that we're going to look for from a nursing standpoint is if our baby is jittery. That's usually the first sign that we see with hypoglycemia. We'll look at our baby and they have just these very small little jittering movements on their limbs or their little legs, like they just kind of shake just ever so slightly. So if we see that, we would want to check a glucose level. And then our GI system. So at birth, the abdomen is flat and we do not have bowel sounds. Gradually, within a few minutes, the abdomen becomes nice and rounded and soft. And then we have bowel sounds within about 15 minutes. All right, let's talk a little bit about bilirubin. So bilirubin is what can cause jaundice, which I'm sure all of you have heard of before. So what happens is when babies are in utero, they have a whole bunch of red blood cells, more than what they need when they're born. And the reason is because they're trying to make use of all the oxygen that they can because they're growing a whole body. So they have all these extra red blood cells that they now do not need. So they start to break down those red blood cells when they're born. That breakdown product is the bilirubin. So we manage that, like our bodies manage that by our liver. So our liver kind of takes up that extra bilirubin and is able to like conjugate it and do all these fancy things. And then it can get excreted in our urine and our feces. But babies have immature livers. So sometimes their liver cannot keep up with breaking down all of those red blood cells. So what can happen is that bilirubin level rises. And if it rises too high, it can become toxic and it can actually cross the blood-brain barrier and it can cause kernicterus. Kernicterus is like where we have damage to the baby's brain because those bilirubin levels are so high. And then as you know, like when our bilirubin is high and we have jaundice, that's what causes babies to be yellow. So they have this yellow appearance, their sclera, the white part of their eyes can be yellow. You can touch their nose or their chest, and when you like blanch it, it's yellow. So these are all things that we're going to watch out for, and we'll talk about babies that are more at risk for having issues with jaundice and high bilirubin levels. And then one of the things that we can do to treat this, depending on the level, would be phototherapy or those Billy lights. And so the light waves from the Billy lights actually help to conjugate that bilirubin, and so the baby's able to excrete it. If the bilirubin levels are really high, then they're not able to use phototherapy, and instead they do they actually will transfuse the baby with different blood. So that would be a very severe case of really high bilirubin. But the whole point is to try to prevent this kernicterus. We want to protect that baby's brain. Okay, let's talk a little bit about poop. So stages of stooling. So those first couple of days, we have meconium stool, which is this bottom picture here. It's mostly comprised of amniotic fluid and different secretions, cells, maybe a little bit of mom's blood. It's very tacky and sticky and thick. It has kind of like a greenish, blackish color. Usually most babies will pass that stool within the first 24 to 48 hours. If they have not passed their first stool or their meconium within 48 hours, that is a red flag, and that's something that we need to report to the pediatrician. There is something that can occur where like you're doing your head to toe assessment and you see that the baby has a rectal opening, but it doesn't mean that it's necessarily connected to the rest of the baby's bowels. And so those babies will not be able to pass that meconium because it's not connected. Their rectum is not connected to the rest of the bowels. So we always want to report if they haven't had a meconium stool within 24 to 48 hours, kind of go on your protocol of your facility, but just something we want to watch out for. And then we also talked about how some babies will have that first bowel movement when they're in utero. So that's where we get that meconium stained amniotic fluid. Now, around day 3, after we've had plenty of feeds, whether it's breastfeeding or bottle feeding, that stool will start to change and we have this transitional stool. So it goes from that greenish brown color to a yellowish brown, less sticky. And there's like some small, like it says curds, but like it can be seedy if it's a breastfed baby. So there's just more form to it. And then gradually around day 4, day 5, we have our milk stool. So if it's a breastfed baby, that stool is going to be this yellow color up here. It's kind of pasty and it smells like sour milk. A formula fed baby also is going to have kind of yellowish to light brown stool. It's going to be a little bit more formed, and it may have a little bit worse odor. All right, and then behavior of our little babies here. So those first hour to maybe a little bit after that, babies are very alert and active. They have good sucking activity. Their heart rate may be elevated. They might be breathing a little bit faster because they're making all of those transitions. You may hear a little bit more like wetness in their lungs. But once again, this is when they're most active and alert that first hour or so. And that's why we try to really initiate that bonding, that skin to skin, and that first feed, because you're going to be most successful. This is really a time that we try to encourage our family to not have visitors. Now that's completely up to them, but that first hour is just so important for that bonding. And a lot of times that first hour, the doctor's still in there, maybe doing a repair, getting mom comfortable. We as the nurses are cleaning up everything, documenting our little hearts out. So there's a lot of activity. So having all your visitors come in can be really, really overwhelming, and overwhelming to this baby too. So what we try to do is like dim the lights once we get everything kind of put away, mom cleaned up, dim the lights, put them skin to skin, try to initiate that first feed, and just have them have that hour to bond. All right, so then after that initial hour or so, we have a period of decreased activity. So now that baby is worn out after the whole birthing process and that first feed, that's a lot for this little baby. So they're going to be less alert, less active. They're probably going to go to sleep, and those vital signs will start to stabilize. So this may be a good time to have some visitors, or maybe for mom to get a little bit of rest finally. So just depends. Everybody's different on what they want. I always feel like after I have my babies, I have like this high. I get very just like, I'm just over the moon, so excited to be like done with that process. And so I would welcome anybody, come on and let's celebrate. But I also had pretty quick labor. So I can imagine if I was in labor for days and days, I think I probably would feel a little bit different about having a bunch of people in there. And so then obviously you're going to have another period of reactivity, and then it kind of cycles from there. But during that second period of reactivity, obviously we're going to feed again. This is also the time where those bowels start to work a little bit more. Now they've had a couple feeds. And so this is a common time frame where the baby may pass that first meconium. You also may see more like gagging or spitting up because the baby's kind of working up all that fluid and stuff still. So good time to just educate on that bulb syringe, and making sure that parents know that that is a very normal thing and how to respond to that. We're still working on feeding, breastfeeding. If it's a first time mom and she's breastfeeding for the first time, she is going to need help probably the first several times that she breastfeeds. And then always answering questions and doing your normal prenatal, or postpartum care. All babies have pretty distinct sleep-wake states that they go through. I think this picture is from your book. It's either from your book or the one we used previously. But so we have A there, which is like a deep sleep state. B is light sleep. So even those that B there, babies can make a lot of noise, but they're actually asleep. They're in that light sleep. C would be drowsy. So that would be a good time to kind of start getting them settled for sleep. D is quiet alert. So usually during that time, they blink more slowly. They're avoiding eye contact. Hopefully they've already been fed, and you can start kind of getting them settled down for a little slumber. E is active alert, and then F is crying. So some babies just kind of go through these different states really easily, and other babies need a little bit of help making these transitions. So just kind of depends on what's going on with that baby. So one thing I think of quite a bit when I get to this slide is our NAS babies, or our babies that are born to mothers who use some type of substance like drugs or alcohol. So they really do have a lot of issues kind of transitioning through these wake states and getting to sleep and getting settled. And so we have things that we can do to help with that: swaddling, rocking, lowering the lights in the room, getting rid of any kind of unnecessary noise. Things like that can help them make those transitions. So these are things that most newborns have these behavioral responses. This is from your book as well. So orientation would be that they respond to stimuli like lights and sounds in the room. Habituation is the ability to process and respond to auditory and visual stimuli, and then the ability to block out external stimuli once they're used to that activity. So, this is the first time that they've been in this wild, crazy, loud, bright world. So once they kind of get used to that, they tend to do better. Motor maturity, so ability to control their movements, that takes a little bit of time. Self-quieting ability or consolability, so kind of the same thing. Some babies are really easy to console and can console, and others need some assistance. And then social behaviors like cuddling and snuggling and being held close to somebody or skin to skin. And there's a sweet little baby. Okay. No, let me save that one. Okay, that wasn't too bad. All right, let's do this last one here. I think we're done at 1 today, right, guys? Yeah, okay, perfect. So we will have a little bit of extra time. So for anybody who wants maybe additional math or something like that, we can go through that. This next one's, I think it's got 53 slides, but it won't take me the whole time. So I'm just gonna jump right into it so we can get it out of the way. Does anybody have any questions before I start going? Okay, let's do it. All right, so this is all about more in depth about like what we do as nurses to in these first few hours of taking care of a newborn. So our initial newborn assessment, we do quite a few different assessments, but right when the baby is born, pretty much simultaneously. So the baby comes out, we are drying that baby because we want to prevent that evaporative heat loss. We are stimulating that baby. So gently rubbing them, kind of rubbing their back, maybe rubbing their feet, because that will stimulate them to take those first few breaths. We are assessing our ABCs. So just like any other scenario, we're always watching our ABCs: airway, breathing, circulation. We're assigning an APGAR score, which I'll tell you what that is in a second. We are encouraging skin to skin. So typically before birth, I try to have this conversation ahead of time, and I ask my patient, my mom, do you want, when the baby's born, do you want the baby directly up on your chest or your belly? Because they're dirty, they're gross, they're slippery, and they got all kinds of goo on them. So some people, they're not really down for that. They want their baby cleaned up and then swaddled and brought to them. So having that conversation ahead of time is really nice if you can, because if you are not wanting your sticky little baby on you immediately and somebody does that, then that can be, kind of upsetting. So anyways, having that conversation ahead of time is wonderful. If they want to do skin to skin, we definitely encourage that. And so we would put them right up on mom, and then we would do all of our care while baby is on mom. We do give some meds during that first hour, so I'll go over that in a little bit. And then we always try to keep mom and baby together whenever possible. So as long as they are both stable, they will stay together. As far as resuscitation and stabilization, so I'm not going to go into like a full, like what a resuscitation would be. This is just kind of our general thing. So we're going to dry our baby, we're providing warmth, and we're doing that tactile stimulation. Sometimes that little bit is all that baby needs to be able to, like if they come out kind of stunned and they're not taking those first breaths, just those interventions of drying and stimulating can be enough to kind of resuscitate the baby in that moment. We're going to clear the airway with a bulb syringe. All delivery kits come with a bulb syringe, and usually we have quite a few in the room as well. So just trying to get those secretions out. And then if we do need to do a little bit more, we can cut that umbilical cord. The provider will cut the umbilical cord, and then we'll bring baby over to the warmer that's in the room. And another thing that we can do is just position the baby into this, it's called a sniffing position. So it brings that chin off of the chest. We don't want to hyperextend, and we don't want to hyperflex. So it's just the sniffing. Their nose is up just a little bit in the air like they're sniffing. And that right there can help open up the airway a little bit, and then just give them that little bit of assistance when they're taking those first few breaths. So that might be the end of our resuscitation, is just doing those couple of things. And then we may need to do a little bit more suctioning. And then when we're doing all this, we're constantly evaluating the respiratory rate, the heart rate, the color, and the tone, which is all part of this APGAR score that I'll tell you about. When we are expecting a delivery, so we have time to kind of prepare, when we bring that warmer into the room, or if there's already a warmer in that room, we connect all of our equipment and test it. So our oxygen, our suction, we test all of that ahead of time in case we do need it when baby is born. So if in this scenario, if we need to give baby a little blow-by oxygen, or maybe we do need to bag them a little bit, all of that's available and has been tested for us already. And then of course, if we're going like full scale resuscitation, then we would do medications and compressions on all of that. This NRP is the neonatal resuscitation program. So it's like the BLS, but for newborns. And so if you work in this area of nursing, you will have to be certified in NRP. And so now you know how to conduct that that resuscitation. You will also have to be ACLS certified. So you'll know about those meds and kind of the series, the algorithm that we follow for that resuscitation of our adult patients. Okay, APGAR. APGAR is another lovely little acronym or mnemonic for you guys to learn. So the A is for appearance, which we're talking specifically about the color. P is for pulse, or the baby's heart rate. G is for grimace, or their reflex irritability. I have another slide to kind of further explain this. A is activity, or their tone. And then R is their respiratory rate, or their effort. So we assign an APGAR score. We as the nurses give this score, whoever's kind of the baby nurse in that delivery. Usually one person's with mom, one person's with baby. We give this score at 1 minute, and then again at 5 minutes, and then sometimes there's even a 10-minute APGAR, so it just depends on the scenario. Each one of these parameters is scored from either a 0, a 1, or a 2, and so the maximum that you can get is a 10. So here's a little table so you can kind of see how that scoring would be done. We use an APGAR to kind of determine the intensity of the needs of that baby. So do we need to initiate some type of intervention or resuscitation? So if APGAR score is below 7, we need to do something. And it could be as simple as getting them into that sniffing position, maybe giving a little blow-by oxygen. If it's really low, APGAR is below that, we're probably going to need to actually initiate like our NRP algorithm. Scores that are 8 or above lets us know that this baby is transitioning really well, and we don't really need to do any interventions other than our standard drying, stimulating, and suctioning. So here's a little breakdown of our score. And then you can also watch this YouTube video if you want to see somebody like assign an APGAR score. For my students, you're not going to be given like a scenario where you have to assign an APGAR. I just want you to know the general information about an APGAR. So don't worry about memorizing that table, but I want you to know what an APGAR score is and what's a good one, what's a bad one, and what do we use it for, type of things like that. Okay, so some abnormal initial assessment findings, and there are a ton, but these are just some like common abnormals. Flaring, so those nostrils are flaring out, or chest retractions, that grunting sound on exhalation, or labored breathing. If we see central cyanosis, so blue around the baby's lips or mouth, flaccid body posture, so they don't have tone, their limbs are not pulled into their chest, they're just kind of flopped out. Any kind of abnormal breath sounds or abnormal respiratory rate, abnormal heart rate, and abnormal newborn size. So we'll talk a little bit about looking at newborn size and kind of figuring out like their developmental, like how far they are in development. Okay, so I mentioned these medications. So we give 2 medications with consent from parents. These medications are given usually within the first hour after delivery. They don't have to be done immediately, but usually it's right in that first hour. And we can give these medications while mom is still skin to skin. So that's how I typically did it, is maybe, baby's still on mom's chest, she's doing her thing, and then I can still give my meds. So the first one we do is little eye goop or eye prophylaxis. This helps to prevent if baby were to be exposed to gonorrhea and chlamydia via the birth canal, we know that can cause neonatal blindness. And so by giving this eye prophylaxis, it's erythromycin typically, it's an antibiotic ointment that would prevent that bacteria from causing blindness in that newborn. So like when we talked about STIs, we know that it's not like you have intercourse and then you go get tested for STI and everything just lights up positive. Sometimes it can take time for that to reflect in your lab results. So let's say you had intercourse a few days or a few weeks before delivery, and then you show up to the hospital, we do our normal labs and everything comes back normal. That doesn't mean that you didn't have exposure and that bacteria or virus couldn't be in there. It's just maybe not detectable yet. So baby would still be exposed to it. So anyways, this is prophylaxis, and it just prevents that in case it were to be in case baby were to be exposed. Anyway, so our procedure is, obviously we do hand hygiene, we put gloves on. This medication comes in a one-time little tube. So we'll open that up and then we lay a little ribbon of it across the baby's eye in their lower conjunctival space. And we try to kind of open the eye, obviously, and then just put it in there. We don't touch the metal tip to the baby. And then we don't rub this in and we don't rub it off. We just let mom or whoever know to just leave it there. It'll get absorbed and, be good to go. And then the other thing that we do is vitamin K. This is an IM injection that we give in the thigh, in the vastus lateralis, and this helps with clotting. So once again, these newborns have immature livers, so they don't have the same clotting factors just yet. And so what we do is we give them this vitamin K, and it helps with clotting, and while they're kind of maturing that liver. Eventually they'll be able to clot like normal, but there are a lot of instances in those first few days or weeks of a newborn's life where they can experience bleeding. So I think of any kind of procedures that they have, like circumcision or something like that, or any kind of trauma that maybe they experience through birth and maybe they have a hematoma or something like that. And so giving them this vitamin K truly is life-saving. So it's IM, one-time dose in the thigh. All right, first bath. So I said that we try to delay this until baby's temperature is stable. We can do this under a warmer. Not everybody does. I usually just use like warm blankets and stuff, but it doesn't matter. Warm water, mild soap. We try to get everything gathered that we're going to need. And obviously we're never going to leave our baby unattended. For this first bath, you do need gloves because baby still has amniotic fluid and vernix and blood and vaginal secretions. So we need to use our standard precautions. And here's this little baby getting its bath. This one's getting its little erythromycin ointment and then vitamin K. Okay, and then our kind of our head to toe, like our full assessment that we do, we try to have that completed within the first 2 hours after birth. And this can be done by the labor and delivery nurse. It can be done by the baby nurse that came in, or maybe there's a separate nurse. Where I worked, we had transitional nurses that this was their job, is that they would come to every delivery and they would do all of the baby care. That's probably why I don't like taking care of babies, because it wasn't part of my job. So love them. Anyways, so it's a head to toe, just like any other head to toe, but of course it's we change things based on our patient population. So I will walk you through the aspects of a normal kind of newborn assessment. And this is also something that we'll practice in lab. So we try to do the least disturbing aspects first. So if baby's nice and calm and swaddled, we can slide our stethoscope like into their little swaddle and we can listen to their respiratory rate and their heart rate. I always try to get the temperature too when they're still swaddled, and so they're not as bothered by that temperature probe. And then we just kind of go head to toe with the rest of it. Some general things that we're looking for would be the tone, the baby's tone. So do they have their limbs nice and pulled in, or are they really floppy? Also their movement. So we should be seeing them move their right and their left sides equally and symmetrically. Their overall color. So something that we're going to see on newborns is this acrocyanosis. Acrocyanosis is where your hands and your feet are blue, but the rest of your body is nice and pink. That's very normal for a newborn. That just tells us that the majority of their blood flow is going to their most important organs. And then that kind of leaves their extremities with enough blood flow that they're still perfusing, but it just causes them to be a little bit more blue. So that's acrocyanosis, very, very normal finding. Something else we may note is that jaundice that we talked about. We look at their overall body size, their reactivity, or, just kind of how alert they are, if they're responding to us. And then we'll put their ID bands on if they're not already on. If they are on, we just verify that everything matches in their record as far as like the numbers and the names and all of that. Okay, so some more just kind of general things that we're looking for. So I mentioned symmetry, I mentioned cyanosis. So we're going to see acrocyanosis, but we should not see central cyanosis. Their heads are typically going to be large in comparison to the rest of their body. They have little short necks and their chin often will rest on their chest. They typically will maintain a nice flexed position with tightly clenched fists. Their abdomen is nice and rounded or protuberant. Their chest is rounded. Their shoulders kind of slope down. They have rounded hips and their body appears long with stubby little extremities. General weight, and this probably is different depending on your source, but somewhere around 5 pounds, 8 ounces to 8 pounds, 13 ounces. And as we've learned with our math, it is common for them to lose weight within those first few days, up to about 10%, but they do regain this weight within about 7 to 10 days after birth. That's something their pediatrician watches very closely for. And then they gain approximately 2 pounds every month until they are about 6 months old. Their length is somewhere around 19 to 21 inches. We also will do a couple additional measurements. So we measure their around their head, which is their frontal occipital circumference, and that's around 13 to 14 inches or 33 to 35.5 centimeters. And then we also use a measuring tape around their chest, and that's typically around 12 to 13 inches or 30.5 to 33 centimeters. So normal vitals, that respiratory rate is 30 to 60. That heart rate is going to be the same as it was in utero, so 110 to 160. So those hearts still beat very, very quickly. It could be kind of tricky to assess a fetal heart rate because it's so fast. And it can also increase up to 180 beats if they're all worked up. And then temperature, once again, just kind of a general range here from about 97.7 to 99.5. And then blood pressure is not something that we routinely measure. So you guys don't have to memorize that, but just wanted to mention it. Now, if you go on to work in the NICU, you will be getting blood pressures on babies, but that's definitely not a standard thing as a labor nurse that we would ever get. Our gestational age assessment. So we know that a preterm baby is any baby born prior to 37 weeks. So between that 20 weeks all the way up to 36 plus 6, that's a preterm baby. A term baby would be 37 plus 0 up was a term. Post-term or post-dates, these kind of are all interchanged. So that would be like after 42 weeks or post-mature after 42 weeks. And then we also will call babies SGA, AGA, or LGA. SGA is small for gestational age. We'll talk more about that, I think, next week. AGA would be appropriate for gestational age, and LGA is large for gestational age. So basically, that's just saying that if we think this baby is 38 weeks, we have a reference range for how big that baby should be. And is that baby less than that or more than that, or does it fall within that reference range? So we have something called a Ballard score that we do, or we can do. Once again, this is something that those transitional nurses did for me, so I've actually never calculated a Ballard score. But it is a way that we can assess gestational age based on two different categories: the neuromuscular maturity of the baby and then the physical maturity. So it's certain findings that we can look for and we tally up and give points, and that allows us to see if if it matches up with what we thought their due date was. So it's another way to kind of verify that due date. But as we know, not everyone gets prenatal care. So if we have this baby come out and we truly have no idea what their gestational age is, we can use this Ballard assessment to give us an idea. So let me see here. Okay, I thought I had an example of it. So here is I don't know, system, I guess, that we use. So a lot of nurses will have like a card laminated with this picture, and that way they can quickly reference it. But if you're calculating a Ballard, so for your neuromuscular maturity, you do these different position changes with your baby, and you try to see kind of their flexibility. Like this one here is showing you the square window. So you have the baby, you move their hand and see how much they can flex their wrist. And then you would give them points based on how much they can flex it. And then like down here, you would do like a physical, like look at the baby, like lanugo, which is that hair when babies are really hairy on their body. So you kind of score that. And then over here, you would add up your total and then correlate that with a gestational age. Does that make sense? I know that's a lot of information. I know for my students, I'm not going to expect you to calculate a Ballard score. I just want you to know what a Ballard score is, what do we use it for, but I'm not going to give you an example of 7 of these different things and have you calculate a Ballard score. So, okay, so let's dive into that head to toe. So first we're going to look at, or not first, but at some point we're going to look at baby's skin. So these are some common things that we can see on our newborns. So right here is a little Mongolian spot. So it looks like little bruising on their booty. It's not bruising. This is just very normal. These are stork bites that you can see on their neck. This is that lanugo, which is baby little hairs. Preterm babies typically have more lanugo than term babies. This is milia. They look like little white pimples on baby's nose and cheeks. Here's a picture of acrocyanosis. So you see these little twins, they're nice and pink, and then their hands are blue. So that's acrocyanosis, very normal. And this is vernix. This is that cheesy white substance that babies have. It just helps to protect their skin. Preterm babies typically have a little bit more than post-term babies. They also can just have like an overall rash, like red rash across their body. That's called a newborn rash. So these would all be normal findings that you would see, but we do document them. Usually there's like a flow sheet where you would mark these things, but they're normal. And then if we're talking specifically about baby's head, so everything we're looking for symmetry. So if we look straight on at this baby, do we see symmetry in their head? We're going to check their fontanelles or those soft spots. So we have an anterior fontanelle right up here at the front. It's diamond shaped. So we should be able to feel this opening. It should be nice and soft. It shouldn't be bulging. It shouldn't be sunken in. We can also feel the back soft spot or the posterior fontanelle. That one's triangle shaped. So that would be back in here. And then some common variations that we might see would be that molding. Remember, molding is like a cone head from the baby coming down the birth canal, and those skull bones kind of shifting. It creates that cone head appearance. And then also caput succedaneum or cephalohematoma, which I have a different slide on that. So something that we can see kind of frequently in our newborns are these bumps on their head. And we need to make sure that we can differentiate what's causing those bumps. So a caput succedaneum, we call it caput just for short, is where we have this collection of fluid. And we know that this is caput because this bump or this collection of fluid crosses over multiple skull bones, and it crosses over this suture line. So let me go back over here. In between the skull bones, these lines in between here, these are called suture lines. And so if you have a big bump on the skull and you feel that bump go over the suture lines, that would be caput because it's just under the scalp. The fluid is just under the scalp. It's not under the bone. So it's able to cross over those suture lines and lay on top of multiple skull bones. So it's very superficial. It resolves very quickly. And it could just be that baby was coming down the birth canal kind of a wonky way, put a lot of pressure on that skull, and then we just had that fluid build up. Now, a cephalohematoma is different in that it's underneath one of those bones and it's blood. So hema, blood, a collection of blood underneath one of those bones. So it does not cross the suture lines because the suture lines are the area in between the bones. And this is a collection just under one bone. So it would not cross over the suture lines. This is a little bit more traumatic. We can see this maybe if it was a vacuum extraction delivery or they used forceps, or if just baby was in there really, really wonky and we just had a chance for that hematoma to form. These can take weeks up to sometimes months to resolve, but they do resolve. Okay, so more about our head. So I wanted to include some pictures here. For that soft spot, that anterior soft spot, here's one that's sunken in. This could indicate dehydration. And here's one that's bulging a little bit. That could be increased intracranial pressure. This is also a good picture of our suture lines. Sometimes those sutures and those skull bones can lie on top of each other just through like fitting through the birth canal. Those bones kind of shift and they can move on top of each other. And so our suture lines are called overriding, where they're over top of each other. So that's what you're seeing here. They can also be really wide. So we can have a lot of space in between the skull bones. So those suture lines are much wider than usual. So these are all things that we can visualize or we can palpate. Okay, so then looking at babies' eyes, most babies have kind of a bluish gray color to their eyes. They typically do have swollen eyelids like this little one down here. The sclera or the white part should be nice and clear and white. Their pupils should be equal and reactive and they have that red reflex. They have kind of uncoordinated eye movements or like they kind of go in different directions. That's very normal. They can perceive light and they can track objects, but their vision is only about 8 to 15 inches from their face. So that's why we try to keep mom and baby skin to skin, like face to face, chest to chest, because then they can see. They can cry, but they don't produce tears just yet. Really, really preterm babies, like a 22-weeker, 23-weeker, their eyes are actually still fused. They will gradually open, but kind of a crazy thing that they can't even open their eyes yet. And then looking at baby's little nose, so it's typically pretty flat. They don't have a bridge. Their nostrils should be patent bilaterally, so they should both be open. And we shouldn't see any of that flaring. Remember that nasal flaring indicates respiratory issues, so we don't want to see any kind of flaring. Their mouth, so mucous membrane should be nice and moist and pink. We may see some calluses on their lips just from sucking. We look at their uvula, which is that ball in the back of the throat that hangs down. It should be midline. We check the suck and gag reflex. So if we put a gloved finger in their mouth, they should suck on our finger. That's a reflex that we need to check for to make sure neurologically they're intact. And then we also can insert that finger back just a little bit and cause them to gag a little bit. I know that sounds awful, but it gives us reassurance that neurologically they're doing well if they have that suck and gag reflex. We check their palate. So when we have that gloved finger, we're going to run it over the top of the roof of their mouth, and we want to feel that their palate is intact, because you can have a cleft palate but no cleft lip. So if you look at the baby, you don't see any abnormalities, but then their palate is actually not connected, which is actually what this first picture is. This baby has an open palate right here, or a cleft palate. Babies should have well-developed fat pads on their cheeks. Their cheeks are really, really fatty. You might see little white spots on their palate. Those are called Epstein pearls. Those are normal. They may even have a tooth or teeth already. Those are precocious teeth. And then we would do our head circumference around this time. When we're looking at the ears, we want to see where they are at in relation to the outer canthus of the eye. So if they are low set, we need to report that. Their top of the ear, or the pinna, should be nice and flexible and should quickly recoil. So if we fold it down, it should pop back up. Preterm babies do not have that, so their ears often are kind of like smashed and they will stay folded. Gradually that will improve, and then we do a hearing screen on all babies as well. So a hearing screen is like a machine that they get hooked up to check their hearing. Okay, so some abnormals that we can see, obviously there are more, but these are just some. So low set ears, discoloration in the sclera, cleft lip or palate, absent red reflex, microcephaly, so a small head, hydrocephaly would be a large head. Cranial synostosis is where those skull bones have fused prematurely. And we might also see some characteristic features of fetal alcohol syndrome or maybe some other type of disorder. All right, so then kind of working our way down the body. For the neck, we said it's short and it's thick, but they should have full range of motion, so they should be able to look right and left. We shouldn't be able to palpate any masses. We shouldn't see any kind of webbing. They do have a significant head lag, because that head is heavy, but they can, like this person here is holding the baby up by their arms. They should have good tone. See how the baby's kind of pulled in? That's good tone, and they should be able to pull their head up when the rest of their body comes up. It just comes up a little bit after the rest of their body. As we work our way down, we're going to feel their clavicles. So we're going to palpate both clavicles and feel that they are intact, hopefully. Something that can happen during delivery is a shoulder dystocia, which we've mentioned a little bit here and there, and I'll cover it next week. But with a shoulder dystocia, the shoulder gets caught, and oftentimes that clavicle can get broken in that process. So we want to check that. All right, so our chest, here's somebody's doing that chest measurement here. You use the nipples as your reference to where to put your tape measure. We should see symmetrical expansion. We're going to check our respiratory rate if we haven't already. Babies are nose breathers. That's just how they breathe. We're going to look for any signs of distress, so any flaring, grunting, retractions. We're going to listen to any other abnormal breath sounds. There's our normal chest circumference again. Some common variations you might see could be accessory nipples. So they would be along the mammary lines. They could have extra nipples. And you may see some gynecomastia, which just means like swelling of the breast tissue. All right. So I just love this little baby so much. So babies have a nice barreled chest. They do have a prominent xiphoid process. Chest movements are equal bilaterally and they are synchronous with the abdomen. So the chest and belly rise and fall together. They may have breast enlargement or engorgement and maybe some extra nipples. So all that's about the same. All right, looking at the belly. So it should be dome shaped and like slightly protuberant. We're going to see diaphragmatic respirations, should be nice and soft to palpation. You should be able to feel any masses. We're going to look at this umbilical cord and look at this clamp and make sure that the clamp is on there securely and we don't have any bleeding. Babies can bleed out very, very quickly. So we need to make sure that that clamp is on appropriately. You also want to make sure that clamp is just on the umbilical cord and not the skin. What can happen sometimes is the baby's belly button has skin that kind of comes up on one side of the umbilical cord and not the other. So when you put that clamp on, you can accidentally get the skin of the belly button. So really look all the way around to make sure that clamp is just on the cord. The cord itself, we shouldn't see any swelling, drainage. We shouldn't smell any odors. It shouldn't be red. And we should be able to see the vessels still. So once we cut that cord and you get like a cross section, you can see one big vein and two small arteries. So you can still see that with that cord clamp on. It's pretty cool. And then we always want to keep that cord, to air dry. So you see how this baby's diaper is below the umbilical cord. We want to leave that area uncovered. If we cover it, we're more likely to get an infection. So open to air.
Is it supposed to be so many inches away from the belly button or does it
The
matter?
diaper?
No, the clamp.
Oh, no, just as long as it's not touching the skin. So some people will put it on like really high and then you have this big floppy umbilical cord and I always will like go and put another one lower and then cut that other one off. But as long as you don't have the baby's skin and you've got a nice like clamp on there,
Our
you're
students yesterday in clinical, Tony just mentioned our vaginal birth
Yeah.
got to see two vessel cord.
Yeah, that is cool. So every once in a while, you'll have a cord that only has one artery. You've got one vein and one artery. That's not the standard. And sometimes those babies have issues with growth. Other times they do totally fine. That's something that they can identify when you're pregnant on ultrasound. They can know ahead of time that you have a two vessel cord. And so they may just do additional antenatal testing just to check the baby's growth and make sure that they're getting enough. But yeah, some babies do just fine with
Isn't
two
that
vessel
funny,
cord.
Alicia and Tony?
Very
That's
cool.
kind of the same exact scenario. It's kind of cool to see it put into practice.
Yeah.
Uh-huh.
Yeah, it's a real
100%.
thing. Okay, and then we do look at the genitals and the rectum. So babies should have their first void, like urine, within 24 hours. A lot of them come out peeing. It should be a nice steady stream, light in color, no odor. Both males and females are going to have swelling in their genitalia and maybe some discharge. And there's always a possibility of ambiguous genitalia. What that means is that if you just look at your baby, you cannot assign a gender. It's neither female or male. And that does happen. And that's where they will do more testing and look at the chromosomes, the sex chromosomes. But as we talked about, that's not always XX or XY. So there are some caveats to all of this gender stuff. If you can't assign a gender, there is usually in your charting flow sheet, there is an option for ambiguous. So for our females, the labia and the clitoris may be edematous or swollen. We may see a hymenal tag. We would want to report if we have an imperforate hymen. And then we may have a pseudo menstruation, which is just like a little bit of bleeding, like a fake period. It's not a lot of bleeding. It's just a small amount of bloody discharge. It's from the maternal hormones, but that's always something that you would want to tell the parents about because that can really scare them if they see blood in the little girl's diaper. So just tell them what it is. It's from mom's hormones, very normal. Our male babies, so we want to check their penis and we want to check the urinary meatus. So typically it would be coming out from the head of the penis right in the center, but we can also have something called epispadias or hypospadias, where that urinary meatus is on top of the penis or below the penis. So that was something that we would need to let the pediatrician know, and they're able to surgically correct that. Those babies can't get a circumcision because they actually use the foreskin in the repair of that hypo or epispadias. What else? We check for the testes to make sure that they are descended down into the scrotum. So preterm babies, sometimes they are not descended yet. So that's something we would note. And then there's something called a hydrocele, where you can have a hernia in that part of the bowels that comes down into the scrotal sac. And then we do an anal assessment. So like I said, you can have the anal opening, which you would note, but it may not be connected to the rest of the bowels, and we don't know that. And so we want to monitor for that first meconium stool. If we don't see it in the first 24 to 48 hours, we're going to report that to our pediatrician. Just a little bit about circs here, circumcision. So risks would be bleeding, infection, adhesions, and pain. Benefits, it has been shown to decrease the incidence of UTIs and other infections like STIs. And there is prevention against penile cancer. Once our patient does have a circumcision, we are observing for bleeding and any signs and symptoms of infection, any kind of voiding difficulties. It's a pretty quick procedure. There's different types of they're called clamps that they use to remove that foreskin. So it just depends on the surgeon who's doing the procedure. It's done usually in the nursery. Babies are given lidocaine to numb the area. Sometimes they're given Tylenol as well for pain control. And then we use this little sugar water called Sweeties for them to suck on, which also helps with their pain, and sucking is a comfort measure for them. So we do all of those things to keep them comfortable. Usually the worst part for these babies is just laying them down on that circ board. They don't want to be laid down on anything, and because we have to strap them down just for safety that they're not moving around. But we swaddle their top half. We keep them nice and warm and comfortable. Afterwards, we use petroleum jelly on the penis, and we give that to the parents as well. So for every diaper change, they put a big old glob of that petroleum jelly, and that way that fresh skin isn't getting stuck to the diaper. So that helps keep pain control as well. And then we're just watching really closely for signs of infection, bleeding, and then making sure baby's having wet diapers appropriately. And there's a video. This video is not, I think it's like a, I don't think it's a real baby getting a circumcision. I'm pretty sure it's like a cartoon, but it kind of just shows you the steps if it is something you want to watch. Okay, musculoskeletal assessment. So normal findings would be that good tone, not too much tone, and also not floppy. Flexion, symmetrical movements. We also look for symmetry in the folds, these fat folds. So you look at the front of the baby and the back of the baby, and their folds should line up. If they don't line up, that could indicate maybe some hip dysplasia, or something with their pelvis that might be a little bit off, and that's causing those folds to not be symmetrical. And then kind of this one here is just measuring your the height of the knees. So if one's lower than the other, that can also indicate something with their hips. We do certain maneuvers called Ortolani and Barlow. So that's where we adduct and abduct the baby's hips. If we hear any kind of popping or clicking, we would want to report that, because that can also indicate some issue with the baby's hips or hip dysplasia. We often see that with our breech babies, because they're stuck in that breech position with their legs up in these crazy ways. And a lot of times they will have issues with hip dysplasia. Any breech baby always has to get an ultrasound after birth. I don't know when they do it because I never did peds. I just know that's like a standard thing, just because it is so common for them to have issues with their hip development. All right. Oh, that's just a picture of Ortolani and Barlow's. And yeah, you see like this cord. Look at all this extra cord here. So if this was my patient, I would take another cord clamp and I would put it down a little bit lower, and then I would cut off this one. You always clamp it before you cut. And this is a little temperature probes. This baby's under a warmer, and there's these little stickies and temperature probes so that they can make sure baby doesn't get too hot under that warmer. You can also see all the ID bands. So babies get 2 ID bands and a security band. This is their security band right here, it looks like. Okay, neurological assessment. So normal findings would be that sucking, rooting. So the rooting reflex is if you touch a newborn's cheek, they will move in the direction. So if you touch their right cheek, they're going to move to the right and vice versa. That's the rooting reflex. That's something we check for. Grasp. So if you put your finger in the baby's palm, they're going to grab your finger. That's a normal reflex. Moro or startle reflex. So if you make a loud noise or you clap your hands, that baby is going to like flail their arms and legs and then bring them back in. That's the Moro reflex. That's a expected reflex. Gag reflex. And then Babinski. Babinski is where you take their little feet and you run your finger from their heel up to their toes. Their toes will splay out and then come back in. That's a positive Babinski, which is a good thing for a newborn. If your adult patient has a positive Babinski, that actually indicates brain damage for them. But newborns, we want them to have a positive Babinski. Abnormal findings. There's many, but just a few here. A brachial plexus injury. So kind of back to that shoulder dystocia. Shoulder dystocia, because that shoulder is caught, that neck gets pulled on. You have this bundle of nerves that runs from your head down your arm called your brachial plexus. So when that shoulder's caught, that neck is getting pulled and pulled and pulled, it can actually damage that bundle of nerves and we can end up with a palsy. And so they actually are not able to move that side of their body or have limited movement. That's a brachial plexus injury. So that's why we're always looking for symmetrical movements. Same thing with like you can have facial paralysis too from maybe like a forceps delivery. So just look for symmetrical movements. Spina bifida, which we'll talk more about. Anencephaly is a condition where the baby's brain does not form. They have a brain stem, but they do not have the rest of the brain. That's something we can see on ultrasound. Same with spina bifida. Any kind of absent or abnormal reflexes, seizure activity, and then like that jitteriness if we need to check their blood sugar. So here's just somebody kind of doing some of those reflexes. So we're checking the sucking and gag reflex. Here's your grasp. This is a reflex where you can hold baby up and they actually take steps. They can't bear weight, but they will start to move their feet in a walking like motion. Here's your startle reflex. And this is called, I think, tonic neck, where you turn them to one side and they'll straighten out that arm and they'll pull in the opposite arm. They should also demonstrate sneezing, coughing, blinking, and withdrawing from painful stimuli. And then here's a video if you just want to watch somebody kind of elicit all of those reflexes. Okay, extremities. So our arms, we're going to get our brachial pulses bilaterally. We're going to look for symmetrical movements. We're going to look at that tone, inflection, full range of motion. We're going to count our fingers because sometimes we can have extra digits. We can look at that the baby's palm and look at their palmar crease. I think I mentioned earlier that some individuals with Down syndrome can have a single palmar crease called a simian crease. So we're just looking to see if they have that. It doesn't necessarily mean that baby has Down syndrome or not, just something that can be correlated. Legs, we're going to get their femoral pulse, so kind of in their groin. We're going to look at tone, flexion, full range of motion, looking for symmetrical movements, checking for symmetry of those folds, and then also we're going to count their toes and get that Babinski reflex. Then we're going to flip them on over. We're going to look at that spine and make sure it's nice and straight and flat. We don't see any masses or openings. Right above their gluteal crease, we're going to look here for any signs of any kind of opening or abnormalities like a tuft of hair, or this is a dimple, a sacral dimple. Doesn't necessarily mean anything is wrong, but it can indicate spina bifida. There are different types of spina bifida, so just like an abnormal connection in the spine. So both of my kids actually have spinal or sacral dimples, but they are, they haven't had any issues with mobility or anything like that. And then here's a video if you guys want to watch someone do a head to toe, and we'll practice this in lab too. So our periodic shift assessments, so vital signs, always looking at baby's color, checking for jaundice, that acrocyanosis might still be there. We do their weight every 24 hours, usually the same time. We assess how often they're feeding and their elimination patterns. That also helps us figure out their hydration status. We can check that Fontanelle as well. We ask mom, how often is baby feeding? How many wet, dirty diapers? We do our listen to our heart rate, respiratory rate, just kind of reactive. How's the bonding going with the baby? Is our mom and dad or the parents responding appropriately to baby's cues? This here is a little transcutaneous Billy monitor. It's something that we can touch on the baby's chest, and it gives us an idea of what their bilirubin level is. So if it's out of range, then we could get a heel stick and actually check their level and then verify if we need to go ahead and do any kind of like Billy lights or something like that. But everybody gets that Billy check. I think that's every 12 hours that they do that Billy check. Oh, this little one's getting a hearing screening. Here's your vitamin K. Another thing that we do is the newborn screening panel or PKU test. So this is, you get a little card that you fill out and it has these 5 circles on it. You do a heel stick on the newborn and then you have to fill those 5 circles with a blood sample from that heel stick. It is so annoying. It takes so long. I hate doing PKUs, but it's a super, super important test because it's screening for certain metabolic disorders. It's called a PKU test, but PKU is just one type of metabolic disorder that it covers. So you may hear people say that it's a PKU test, but it's actually screening for a lot of different things in addition to PKU. But so it's a metabolic screening test. Anyways, there are certain metabolic disorders that we can have. They're genetic, and if we don't know about them very, very quickly and correct that baby's diet, we can have really detrimental effects. And we'll talk about some of those things in our newborn chapters. But we do this test on every single baby. We get results within like a week or 2 after birth. And that way, if they do have any of those disorders, we can start treatment and correction right away to prevent those complications that can occur. We also offer all babies a Hep B. Oh, that's actually probably Hep B that they're giving here. Hep B vaccine. So that would be something that the parents would consent for. And then a hearing screen. All babies will get a hearing screen. This is just kind of revisiting IM injection. So we use that vastus lateralis. We can practice that in lab as well. And then our heel stick. We have special lancets that we use for newborns where the needle isn't as long, and then we poke the sides of the heel. We have little heat packs to help dilate those vessels so we can get a better blood supply. So we do this for any kind of blood sugar testing, and then that PKU test or that metabolic screening test, and then other things as well. We can check for jaundice and things like that. Discharge teaching, postpartum is a lot of teaching. So we try to start that teaching right away. So it's not quite as much when they're going home as they can kind of process that information as we go along. So we're just teaching as we're going. And then right before discharge, we do kind of like a big sit down, 20 minutes of like just general teaching about stuff. So for a vaginal delivery, usually moms are discharged within 24 to 48 hours if there's no complications. And then C-section's about 72 hours. We need to make sure, obviously, mom and baby have normal vital signs, feeding is going well, normal output. We kind of just assess like the homegoing situation. Who is this baby going home to? What kind of environment? What kind of resources? We do any kind of demonstration like bath, diapering, clothing, talk about that umbilical cord and how to care for it. We talk about feeding. We do talk about back to sleep, making sure that they're not putting baby on the belly to sleep and they're in a bassinet or crib by themselves with nothing else in it other than a very tight swaddle, and they can have a pacifier, but no stuffed animals, no blankets, no pillows, nothing like that. So we do a lot of safety teaching. For like car seat, they have to have a car seat, but typically we as nurses, we cannot put the baby in the car seat or help with the car seat just for liability reasons, but we cannot discharge them until we know that they have a car seat. They have to bring that car seat in. So we know that they're going home with a car seat. And then typically we also make sure that they have their first appointment with their pediatrician. So most babies have to be seen within about 24 to 48 hours by a pediatrician after discharge. Okay, just briefly, I've got a few slides here on newborn nutrition. So a newborn's stomach size, day 1, is about the size of a cherry. So pretty tiny. Within a few days, we're up to a walnut. A week, we're about an apricot, and 1 month, an egg, a large egg. So still very, very small, and that's why they need to feed so frequently. Newborn can feed at any time, and a lot of times we just do on-demand feeding. So it can be quite a bit for some babies, especially that second day after delivery. They go through this cluster feeding and they just want to feed all the time. So if you haven't had a baby before, that can be a little bit of a shocker for the parents because you're just so tired and all they want to do is eat every hour. So very, very normal though. They just go through little growth spurts. So we need our babies to demonstrate the ability to suck, swallow, and breathe. Those are the components of successful feeding. Breastfed babies typically will nurse every 2 to 3 hours, if not more frequently, for about 10 to 20 minutes per session. That really just depends on the baby and the mom's supply and her letdown and all kinds of different factors. Formula fed babies typically feed around every 3 to 4 hours, can be more frequently, and they will finish their bottle in about 30 minutes or less. And some, of course, can get that finished much quicker. So it just depends on the baby. All right, so a little bit about breastfeeding. So this is the optimal form of nutrition for the first 6 months to 1 year. It is associated with lower risks of something called NEC that we'll talk about. SUID is sudden unexplained infant death, or like SIDS, ear infections, type 2 diabetes, asthma, and obesity. First, we have that colostrum that Miss Nicole had mentioned. It's a yellow sticky substance. It's got antibodies in it, and it's a very small amount, but as we know now, babies only have very tiny little cherry bellies, so they just need that small amount for those first couple of days. And then gradually that milk will start to transition to what's called mature milk. And so we have more, our supply goes up quite a bit, and that's when moms will have that engorgement. So most of the time that mature milk will come in around days 3, 4, 5 postpartum. Can be different for everyone. A little bit more about colostrum here. So it is thick, yellow, and it's secreted during the first few days after birth. It can actually even be secreted during pregnancy. It's rich in macronutrient carbs, protein, and fat, and it also has immunoglobulin A, which helps protect against infections. Something that's really important, if you do work in this area of nursing, you're going to spend a lot of time helping women breastfeed. I had to take a 12-hour breastfeeding course. It was a 1-day, 12-hour breastfeeding course on top of all the other courses that we have to take, just to get some like tips and tricks to help women with breastfeeding, because this really is a huge part of our job. I was a breastfeeding mother. I breastfed both of my children, and I found it very easy, but I actually find it very difficult to help others breastfeed. It takes a lot of like different skills and practice and techniques, and everybody's bodies are different. Every baby's body is different. So it really is, it's a tough thing to help with, but latch is such a big component of that. So I wanted to include some pictures of a good latch. So you can see how this baby's mouth is wide open and their lips are kind of like out like a little fishy. And that allows that baby to pull as much of that nipple and areola into its hard and soft palate. That's a good latch. That allows that baby to suck most efficiently and allows that milk to get pulled from the breast, which allows the breast to make more milk because it's a supply and demand process. So we need a good latch. It also makes it more comfortable for mom. If we have this latch where baby's just on the nipple, she's going to experience a lot of discomfort. start. So it's just something that we're constantly working on a good latch, and things can make that latch more difficult if baby has lip ties or tongue ties, or if mom has those inverted nipples, or all kinds of different factors. And that's why it's a hard thing to help somebody with, because there's so many different things you have to think about. These are some common breastfeeding positions, and these can really depend on the size of the woman's breasts. Some women do really well with like side lying or football hold, and other women with smaller breasts may do better with like a cross cradle hold. So it just depends, whatever their comfort level is. And then formula feeding. So we need to educate our parents on types of formula, how to prepare it, the storage, the equipment, different positions as well, and amounts to feed. We don't want it to be underfed or overfed. The general recommendation is an iron fortified formula until age 1. And then I think Miss Nicole talked about how to prevent lactation. So if you have a patient that knows immediately that they do not want to breastfeed, we want to make sure that we help them suppress that milk production. We don't want their milk to start coming in, because once it starts coming in, or it does come in, it's a little bit harder to get a hold of that. So right away, if you know that you're only going to formula feed, then we will tell our patients, okay, wear a tight bra, do not stimulate those nipples, and then you can use cabbage leaves if your milk has kind of already started coming in, just for some relief. But we want to suppress that lactation as much as we can if they do not want to breastfeed. Oh, that was it. Yay! Okay, guys, we did